Hello everyone, am I live? Hello everyone. Hello everyone, am I live? Can someone respond in the chat box please? Am I clearly visible, audible? Can we go ahead? You have to give me a minute to open another PPT. Thank you for confirming. Thank you so much. Okay. Students are still joining. We will start in a while. So let's first finish non-communicable disease, followed by one more chapter, healthcare services of the community, and after that we will come on on national health programs. So this is the last marathon we are running now, the last 3 years. Okay, so can I start non-communicable disease? Are you people with me? Can we go ahead? Let's start it and let's finish it. It's a very small chapter. Let me start with the first disease. The first disease here. Now, what are non-communicable disease? I taught you many communicable disease right now. I taught you all the respiratory one, all the GIT one, all the zoonotic one, in which there is one or other infectious organism is there. Whether it's a bacteria, it's a virus, it's a parasite, and causing some infections. Hana? So I taught you these all were the infectious diseases that is communicable. Now I'm teaching you non-communicable diseases, right? So first disease here, we will see 4-5 diseases here. The first most important disease to be discussed here is the obesity. So let's start with obesity. Okay, let's start with obesity. So in obesity, to whom you will call a person as obese? What is the definition of obesity? To whom you will call the person as obese? So there are 5 criteria. The first index is basal metabolic index, BMI, the most important criteria, BMI. So what is BMI? BMI is also known as Quetelet index, basal metabolic index, BMI. It is also known as Quetelet index. Learn its other name. Learn its formula, weight upon height ka square. Do you know your weight in kg? What is that weight in kg? Write down your weight in kg. Do you know your height? Not in feet, in meters. Not in feet, in meters. Your height in meters. Do the square of that. So that is your BMI. You can calculate right now your own BMI. Say, take your weight in kg. See the unit, not in grams, take it in kg, and take your height in meters. If you know your height in feet, you can convert into meters and take it here and do the square of your height. And you can do weight upon height ka square. You can calculate your BMI. Normal BMI, you can see the normal BMI. What is the normal? Learn the normal range. It's 18.5 to 25. Please learn. The normal BMI is 18.5 to 25. Less than 18.5 is known as underweight. And more than 25 is known as overweight. Underweight have no further classification, but overweight is divided into 4 more classification. 4 more. So overweight more than 25. 25 to 30, it's pre-obese. 30 to 35, it's obesity 1. 35 to 40, it's obesity 2. And more than 40 is obesity 3, known as morbid obesity. So please learn based on BMI. This is the classification. So what is BMI? First tell me what is basal metabolic index, also known as Quetelet index. Please learn. Please learn. Hana, the other name. Now what is the formula? Formula is weight upon height ka square. Learning formula is not important. Learning unit is also equally important. Weight is taken in kg and height is taken in meters. So weight upon height ka square. Now what is normal BMI? Normal BMI is 18.5 to 25. Say this is normal. This one is normal. Okay. So can I say this is normal? Okay. Next page. Okay. Normal is 18.5 to 25. This is normal. See, this one is normal. Okay. So I mean to say less than 18.5 is underweight and more than 25 is overweight. So let's write here underweight and let's write here overweight. Overweight. Underweight is just underweight, but overweight is further classified into 1, 2, 3, 4 types based on they all have BMI more than 25. 25 to 30, 30 to 35, 35 to 40, and more than 40. This is known as pre-obese. This is known as obesity 1. This is known as obesity 2. This is known as obesity 3 or morbid obesity. You get simple questions on that. How many of you got it? Can we go ahead? Say yes, give me a thumbs up. This is BMI. Please learn, please learn. If you know the normal, it's very easy to say. Uske aage aur uske piche. Normal is 18.5 to 25. So less than 18.5 is underweight, more than 25 is overweight. But overweight is further classified into 4 categories. They are in front of you. This is based on BMI. We classify obesity. So can I ask you 2 questions here? I have just eliminated here. So, okay. What is normal? 18.5 to 25. है ना? So less than 18.5 is underweight. I taught you. More than 25 is overweight. है ना? More than 25. What is the further classification? What is the further classification? They all are overweight. I know. This is underweight. This is overweight. What? This is normal. Tell me further classification. 25 to 30. 30 to 35. 35 to 40. And more than 40. है ना? So this is pre-obese. I told you very clearly this one is pre-obese. Anna, this is obesity 1, obesity 2, obesity 2 questions. Both are here PYQs. Tell me the cutoff of overweight. Let me write the question. Tell me cutoff for overweight. And tell me the cutoff of obesity. The 2 different questions are there. Can you give me the answers? What is the cutoff of overweight? Anything more than 25, we are calling it as overweight. So cutoff is 25. Straightforward question, straightforward answer. Answer is 25. The cutoff for overweight is 25. But in the overweight, this is pre-obese. This is not obese. So cutoff of obesity is 30. Obesity start at 30. 25 to 30 is pre-obese. They are not obese. So from 30 onwards, they all are obese, whether 1, 2, 3. So please see the 2 questions and please see the 2 answers very carefully. Cutoff of overweight is 25 and cutoff of obesity is 30. How many of you got it? How many of you got it? So please, these 2 are your PYQ. So don't get confused in the option. You always have both the option. Don't get confused. Got it? This is BMI. One more index is there. Can I ask you a question? I don't know the weight. I know only height. Can I calculate? Can I say whether the person is obese or non-obese based on height? I don't know the weight of the person. I'm asking you. I don't know the weight of a person. I know only height of a person. Based on the height, can we comment whether the person is obese or not? Yes, we can do. The formula is Lorentz formula. Lorentz formula is weight free. It depends only on height. See, the formula is complicated, but this is the formula. You have to learn it. Height in centimeters. My height in centimeters is 155 centimeters. So it's in centimeters, not in meters. So height in centimeter minus 100 minus again height minus 150 whole upon either 2 or 4. If we are considering for female, it's 2. If we are considering for male, it's 4. So the formula is height minus 100 minus height minus 150 either upon 2 or 4. Depending if it's female, it's 2. If it's male, it's 4. It's like this. So only height is there. For example, for me, if I calculate 155 minus 100 minus 155 minus 150 upon 2. If I calculate like this. So 155 minus 100. I guess answer is 55. Minus 155 minus 150. Answer is 5 upon 2. 5 upon 2. 5 upon 2. It will be 2.5. So something answer will be there, but I don't know the cutoffs for this. So anyways, so please learn that. This is how we calculate. Okay, the third is the Broca's index. The third is the Broca's index. So height minus 100 is the ideal weight. Again, height in centimeter. That is, my height is 155. I told you 155 minus 100. My ideal weight should be 55. My ideal weight should be 55. Now, whether if I'm 55, I am ideal. Less than 55, I am underweight. And more than 55, I am obese or overweight. Like that. So this is Broca's index. So Broca's index have both height and ideal weight. And fourth and last is corpulence index. So your actual weight upon your desirable weight should be the ratio. Ideally, your actual weight should be desirable only. They cancel each out and answer is 1. But up to 1.2, it's normal. More than 1.2, it's obese. So actual weight upon desirable weight, the ratio should be less than 1.2. Tell me the 4 index. BMI, that is Quetelet index, Broca's index, Lorentz index, and corpulence index. So these are the 4 index till now I taught you. The 5th and the last one for obesity is the skin fold thickness. What is skin fold thickness? We make a pinch. We make a pinch over the skin and measure the thickness. Measure the thickness like that. Where? Over the tricep. With the help of an instrument. The name of this instrument is known as Herpenden skin caliber. Can you see the instrument? It is known as Herpenden skin caliber. Harpenden skin caliber is the name of this instrument, and it is measured over bicep, tricep, है ना, subscapular region, but mainly at tricep. Okay, in boys the cutoff is 18, and in girls the cutoff is 32. Why? Because in females there is more subcutaneous fat, है ना. Females की चमड़ी वैसे ही मोटी होती है, it's thick, है ना. Subcutaneous fat is more, so if you make a pinch, in females it's more, है ना. So in females the cutoff is 32. More than 32 is obese. In males the cutoff is 18. More than 18 is obese. How many of you got it? Let me define obesity. What is obesity? I'm done with obesity. The first disease is done. Okay, what is obesity? In obesity, how many indexes we have seen? We have seen Quetelet index, also known as BMI. We have seen Broca's index. We have seen Lawrence index. We have seen corpuscens index, and lastly we have seen skin fold thickness. Okay, so tell me the formulas and cutoff of all these. For Quetelet index, I told you just a second, I'm sorry, Hannah. I told you the formula, it's weight upon height ka square. Hannah, you have to tell me the units also. The weight is in kg, the height is in meters here. For Broca's, I told you it's height in centimeter, not in meter, minus 100. Hannah, that is the ideal weight. Like for me, it should 55. It should be 55. 155 minus 100 is 155 minus 100 is 55. Hannah, Lawrence is weight free. It contains only height. What is the formula? Height minus 100 minus height minus 150 upon 2 or 4 depending male or female. है ना. Corpuscens index, what is that? I told you it's actual weight upon desirable weight. The ratio should be less than 1.2. If the ratio is more 1.2, the person is obese. And skin thickness, I taught you that we measure the skin thickness with the help of an instrument. The name of the instrument is Harpenden caliber, and we measure it at mainly tricep, and the cutoff for boys is 18 millimeter, and for girls it's 32 millimeter. You have to learn this. This is all regarding obesity. Mainly 99% the question is going to come from here, but you should know all these also. Lawrence, you should know it's a weight-free indicator. So please learn BMI. And for BMI, I taught you the normal values also that you have to learn. The normal value for BMI I taught you is 18.5 to 25. Less than 18.5 underweight, more than 25 is overweight. Overweight is of 4 type, we have done. Okay, so please learn. We are done with obesity. Okay, so that is the 5 indices. Read the question, tell me the answer. According to WHO, the marker of obesity is what? Is it Quetelet index, Chandler index, Pearl index, or Sullivan index? Very easy question. Very easy question. Say the answer. Say the answer, quick, fast. The marker of obesity. I guess you all are right. Of course, it's Quetelet index. That is the other name of BMI. The best among the 5 is BMI. The globally acceptable by the WHO among the 5 indicators is BMI only. That is Quetelet index. What are other index? Pearl index, yesterday I taught you the contraception failure. Anna, the contraception failure. Sullivan index, I told you on day 1. That is that disability free life expectancy. DFLE ka other name. DFLE ka other name is Sullivan index. Chandler index you don't know. Chandler index is I will teach you in microbiology in hookworm. So number of hookworm, number of acts of hookworm per gram of stool. So it is used to see how much is the infection of the hookworm in a community. Number of acts of this hookworm per gram of stool, that is known as Chandler index. So you should know all the index. Yes, it is index for worm. So you should know all the index. The correct answer here is A. We all know that. Okay, so we are done with that. The next is the use and misuse of many substances. Okay, tobacco is the most common substance misused in India. Okay, in males it's 50%. In females it's 20%. The second most common is the alcohol. The third is the cannabis, and fourth is the opioid. So these all are the misused substances, and our most common is tobacco. 40 to 50% of the cancers in India is due to tobacco. If the day government will ban the tobacco, the smoking also, chewing also, both tobaccos are bad. The smoking tobacco will lead to lung cancer, and chewing tobacco lead to oral cancer. Both are carcinogenic. Tobacco is bad. It should be banned. If government ban the tobacco, 50% of the cancer automatically reduces. So this happens. To control the tobacco, there is a strategy. You learn the strategy. The name of the strategy is Empower. AMPOWER strategy. What do you mean by AMPOWER? M stands for monitor. Monitor tobacco use and preventive policies. M for monitor. P for protect. Protect people from tobacco smoking and offer them help to quit. There are many centers now which help the people, which help they are de-addiction centers. These are known as. So they help the people. People have addiction for smoking. One who's a smoker cannot quit the smoking suddenly. If the person is trying to quit the smoking suddenly, he is having many symptoms. The de-addiction symptoms in the body. Got it? De-addiction symptoms in the body. So this is the thing. So protect people from tobacco smoke and help them to quit it. Okay, de-addiction centers are there. W, है ना? P हो गया, O भी हो गया. Offer, O for offer help for quit. O for offer help. W is warn people about the dangers. So on all the packets of the tobacco, always written that it will lead to cancer. It can lead to cancer and it is harmful for health. It is written on all the packets. So warning is compulsory. Without warning, one cannot sell the tobacco. It's always written. E for enforce. Enforce bans on tobacco advertisement. On the TV, via newspaper, radio, no one can advertise tobacco. You may have seen many ads of the gutka powders, like the, what do you say, Rajnigandha, and many brands are there. You may have seen, but they cannot brand tobacco. They cannot brand tobacco. They cannot advertise that. You got my point? And it is very shameful for the superstars who are advertising such products. It should not be done. It should not be done. Because the youth, especially the teenage groups, especially the adolescent groups, they are mad. I have seen they are mad behind these superstars, behind these television stars. They are mad behind. They consider them God. Whatever they are doing, it's like they should do that. So this is like that. So none of the person who is having a huge fan following should do anything on the social media that influence harmful effects on the public. That is my mentality. It should not be done. Imagine if someone is advertising tobacco, anyways, not directly, but indirectly also in the form of the gutka powder and something like that. It's tobacco advertisement only. So the youth is following it. If someone is smoking, although it's written, it's injurious, but who is doing it? Smoking looks so cool, So teenage start smoking also. Okay, so this is the biggest thing. On the social media, it should not be seen. It should not be shown. None of the scenes should be of smoking anywhere in the movies and the serials. None of the scenes should be of tobacco chewing. None of the advertisement should be there. Government should restrict, should follow these rules. Because once cancer occurs, cancer is a very big thing. Cancer do not occur to one person. Cancer occurs to the complete family. एक person को cancer होता है तो complete family vanishes. You can see the treatment is very disastrous. That the surgery, the chemotherapy, the radiotherapy, the complete family shutters. It's very costly also. And even after that, the treatment, the cure is not guaranteed. If it is early stage, it's guaranteed. But if it is late stage cancer, for stage 4 cancer, we don't have cure. So death is the only statement for them. So it's very bad. So 50% of the cancers are due to tobacco. You yourself imagine. The day tobacco get banned from the world, 50% of the cancer automatically reduced. You can think the burden. So you can visit some hospital, the oncology center one day, and you will realize what I'm saying. And in oncology centers, in cancer centers, you will see the real value of life. What is life actually? 1 day of life. For increasing few days, people are investing lakhs. You will realize what is life there, because people know that they are going to die. They have cancer. There is no treatment. It's metastatic. It's stage 4. Still, they will go opt for palliative therapy. Still, they will take the chemo. They want to increase their life as much as they can. So you will realize the real value of life there. I have seen them very closely. That's why I'm saying all this thing to you. So it should be banned. Anyways, let's come on the topic again. So enforce ban on the tobacco advertisement, promotion and sponsorship. No one can sponsor that, and raises the tax. It should be very high taxable. WHO recommends 75% of the cigarette pack price should be the tax. Tax should be very high. 75%, up to 75% of the original price should be taxed, so that it become very costly. Because your tax ke chakkar mein banning is not possible. No, government is getting a very big tax from all these products. That's why government is not banning it. And everything is interconnected. You cannot just de-link everything. Everything is connected with each other. Everything ultimately ends in the political connections. And ultimately, who is suffering? The patients are suffering. Okay, anyways. Can we go ahead? Can we go ahead? Are you there? Can we go ahead? Are you people live? Kindly someone respond. So learn the strategy for tobacco control. AMPOWER. You should know the full form of that, है ना? First monitor, M for monitor, P for protect people, O for offer, help for quit, W for warn, E for enforce ban, and R for raise tax. Okay, can we go ahead? Can we go ahead? The superstars and role models of the country, of any place, the role models, they should not advertise any such product. They should not. It is a very big hit on the society. For them, it's just an advertisement for which they are getting a fixed amount, maybe some lakhs, maybe some crores, maybe. But it is hitting very badly on the society, very badly. They are creating many patients of the future by doing so. Because they are the role model, they have followers, lakhs of followers, crores of followers following them. Whatever they do on the social screen, like the social media, their fans are going to follow it. They should always keep this in mind. So I'm totally against that. Hannah, I've seen that. I've worked in Tata Memorial Hospital nearly for 6 years, and it's a, you may be knowing, it's the oncology specialist unit, Hannah. Not only in India, the complete Asia, it is the biggest hospital, the referral oncology center. Hundreds or millions of cancer patients come there daily, and we have seen the cancer patients very closely. It's very demotivating seeing a metastatic cancer patient. It's very demotivating. It's very demotivating. And when we ask them why they have started, they know that alcohol is injurious, they know smoking should not be done, so the only answer, they are addicted to that. So why they started? They got influenced somewhere, and because of the friends or because of someone, they started, and after that addiction is there, and after that cancer is there, after that death is there, after that the complete family vanishes. So it should not be done. Anyways, let's go ahead. Okay, the next is the hypertension. What is hypertension? Raise in BP. We know the normal blood pressure is 120 by 80. Here the rule of halves is there. This year FMG question, rule of halves. What is rule of halves? So there is rule of half. Rule of half for hypertension. You can see this is the whole community. From the whole community, these are the people who are hypertensive. These are the people who are hypertensive, है ना? लेकिन जितने लोगों को hypertension होता है, actually half of them are diagnosed. The remaining half even don't know that they have hypertension. So that is the first thing. From the one who are diagnosed, only half of them get the treatment. And remaining half, they know they have hypertension, but they don't take any treatment because they think that treatment is not required. It is not giving any trouble to them. From the one who are treated, half of them are adequately treated. The remaining half are not adequately treated. So this is rule of half. From the total who have hypertension, half of them are diagnosed. The one who are diagnosed, half of them are treated. The one who are treated, half of them are adequately treated. Say yes, this is rule of half. Good, you can get it. This is rule of half. Say something. So half are diagnosed. Among the diagnosed, half are treated. Among the treated, half are adequately treated. And among the adequately treated, half of them are adequately controlled. That's it. So this is rule of half. So please learn rule of half holds good for hypertension, and learn this diagram. It was an image-based question this year. This image will be given to you, and they will ask you the disease. They can ask you the name. The name is rule of half, and the name of the disease is hypertension. I hope you got it. Can we go ahead? Okay. Okay, so this is hypertension. This is the new classification of hypertension. You will learn it better in the medicine, I guess. Hana, you know, normal blood pressure, SBP and DBP, systolic blood pressure and diastolic blood pressure. You can see. Hana, this is less than 120. This is less than 80. This is normal. This is normal. Hana, this is normal. And 120 to 130. Hana, and still less than 80. It is pre-hypertension. 130 to 140 and 80 to 90, it's also pre-hypertension. 140 to 160 and it's 90 to 100, stage 1 hypertension. 160 onwards and 100 onwards, stage 2 hypertension. So this is the classification of hypertension. So this is the classification of hypertension, you can see. For preventing hypertension, lifestyle modifications are required. First, reduce the weight. Reduce your weight. The weight should be adequate. It should not be underweight, but adequate. It should be within normal BMI. The person who are overweight, they have high chances of hypertension. Adopt a DASH diet plan. DASH diet plan is Mediterranean. It is full of fruits, vegetables, low fat, low reduced fat, saturated fat, total fat, such a diet. So this diet is known as DASH diet plan. And dietary sodium reduction. Eat less salt. Sodium is present in NaCl. Salt should not be consumed too much. A little bit for the taste. That's it. Physical activity, increase that. And moderate consumption of alcohol. less than 2 drinks per day. It prevents hypertension. So it is not the thing you start drinking from today. And less than 2 drinks per day, a limited alcohol can prevent the hypertension in future. So that is the thing. So coming on the next, diabetes, you can leave. Okay. You know the cutoff of diabetes, no? You may have read this in medicine and pathology at multiple places. Diabetes ka cutoff kya hai? We take 2 sugars. What are the sugars we take? We take the fasting sugar and we take the 2-hour sugar. Fasting sugar and 2-hour. 2-hour postprandial. What is fasting? The person have not eaten anything since the last 8 hours. It is known as fasting sugar. Fasting sugar more than 126 is diagnostic. And 2 hour after eating, after eating, 2 hours after eating, it should, if it is more than 200 milligram per deciliter, it is known as postprandial. So these are the cutoff for the diabetes. I guess everyone knows that. Rheumatic fever, I'm skipping here. I guess you know rheumatic fever. Do you know rheumatic fever? It is also this thing, non-communicable disease. Do you know what is rheumatic fever? It is a disease of children. It occurs in 5 to 15 years. You see, this is a child. Can you see this is diagram of a child? Now this child is having infection, the tonsillitis. Can you see the child is having tonsillitis by a bacteria? The name of the bacteria is group A streptococcus bacteria. Group A streptococcus, gas bacteria. It is the most common bacteria which causes tonsillitis. So you will say, ma'am, it's very common. I also have tonsillitis multiple times in my life. You also have tonsillitis. It's very common. So what is the new in that? The body is forming antibodies against the bacteria, and the antibodies are binding with the antigen. Antigen-antibody complexes are formed. The bacteria is killed. You will say, ma'am, then how rheumatic fever is occurring? Listen, rheumatic fever do not cause by bacteria. It is not caused by bacteria. On the surface of this bacteria, the gas bacteria, there is AM protein. There is an antigen known as AM protein. On the surface of gas bacteria, there is a protein known as AM protein. It's an antigen. The similar AM protein is present in human 5 organ. The similar AM protein. Which 5 organ? The heart, the brain. You can see the 2 vital. Heart, brain, skin. Just below the skin, it's subcutaneous tissue. And below that, we have joints. So heart, brain, skin, subcutaneous tissue, and joints. These are the 5 organs in which AM protein is present. So autoantibodies are actually formed against the bacteria, but they cross-react at the 5 organ. The antibodies are formed for the bacteria, but antibody will get confused. They think it is also a bacteria and they will cross-react. You can see. So the 5 organ have 5 diseases. The 5 organ have 5 diseases. In the heart, there is rheumatic heart disease. In the brain, there is syndrome scoria. In the skin, there is erythema marginatum. In the subcutaneous tissue, there is subcutaneous nodules. And in the joints, there is arthritis. The 5 diseases together known as rheumatic fever. Rheumatic fever is not one disease. Mind it. Rheumatic fever is not one disease. It's a cluster of 5 diseases. You can see the 5 organ having 5 diseases. It's a multi-organ involvement, multi-system involvement. Rheumatic fever is caused by bacteria? No. Bacteria is not coming and causing the damage. It is the antibody which is coming and causing the damage. So can I say rheumatic fever is an autoimmune disorder? Yes, it's an autoimmune disorder. How many of you got it? How many of you got it? So you will see the detail of all these in other subjects. Like rheumatic fever is a very important topic in medicine as well as in pathology. You will see the details there. Can we go ahead? The next is the cancers. Tell me the most common cancer in the world, in India and in the world, in the male and the female. So let's talk about world. Let's talk about world. What is the most common cancer in the world, in the males and in the females? In the males, if you say, my answer is lung cancer. And in the females, if you say, my answer is breast cancer. In the males, the second common is prostate, and in the females, the second common is colorectal. This is, I'm talking about the world. I'm talking about the world. What about India? What about India? In India, the most common cancer in males is not lung. It's oral cavity, because you know the reason. Our government is not banning the tobacco. They keep on chewing. They just could put the gutka there in one corner, keep it for the whole day. So that reason become mutagenic and cancers occur. So that is the thing. So this is the reason. And in females, it's breast only, like the whole world. Initially, it was cervix, but now it's breast only. So in females, it's same as that of world, like breast. But the second most common in the world is colorectum. Here, most common is breast, but the second most common is the cervix, not the breast. Why cervix? Because of early marriage and early sexual intercourse in India. In India, early marriage of the females, early marriage of the girl is very common. So if sexual intercourse occurs before 18 years of age, chances of cervix cancer are more. So here you can see this is a sequence. Got it? Got it? So you should know the most common in male and female in the world, the most common in male and female, and second most common also. Here second most common is lung, you can see. So that is how you have to learn for India as well as for the world. What is the most common cause of cancer related mortality? Cancer related death का most common cause क्या है? Male female में अलग अलग नहीं है. It's lung only. It's lung only. Okay. So what I taught you, tell me regarding the cancers. Tell me regarding the world. Tell me regarding the India, and tell me regarding the mortality overall. Mortality. Who will tell me? In the world, you tell me the male and female. In India, you tell me the male and female. And in mortality wise, you tell me. Huh? You tell me two. First, second, first, second, first, second, first, second, and mortality may tell me the most common. So in world, most common is lung. Second most common is prostate. In India, most common is oral cavity. Male are chewers. They keep on chewing what? The tobacco. So that is the oral cancer. And second most common is lung. Second most common is lung. In the females, the most common is breast. In the world, it's breast. And second most common is colon, colorectal. In India, most common is the breast only. But second most common is cervix because of early marriages. Mortality wise, most common is lung. So please understand the question very properly in your exam, what they are asking. They are asking world, they are asking India, they are asking male, they are asking female. What they are asking? Look for the options. Or they are asking for the mortality. And apart from that, the cancer details you will see in pathology, of course. And pathology, you will see the corresponding cancers and all. So here incidence prevalence is important. The last is blindness. I guess blindness you will study more in detail in ophthalmology. I guess you have a blindness chapter in ophthalm. You have to study in much detail. But here I will tell you, in the world, in the India, the definition of blindness is same. When the visual acuity, acuity is less than 3/60 in the better eye with the best possible correction. Whatever correction has to be done, it is already done. With the best possible correction, the visual acuity cannot be increased beyond 3/60. The person is known as blind. In the world also, in the India also. So cutoff is 3/60. You get questions on that. In the world, the most common cause of blindness is cataract. In India also, the most common cause is cataract. So cataract, motiabind, is the most common cause of blindness in the world as well as India. But second most common cause differ. In the world, the second most common cause is glaucoma. In the India, the second most common cause is refractive errors. So the refractive errors are there. That is the second most common cause. So definition of blindness is same. The visual acuity less than by 360, 3/60 in the better eye with the best correction. You should know this classification. So what is a normal vision? Normal vision is 6/60. 6/60 is normal vision. Okay. If anyone having vision between 6/18 to 6/60. 6/18 to 6/60. 6/18 to 6/60. Just a second. 6/18 is the normal vision. Anyone having vision between 6/18 to 6/60, it's known as low vision. Anyone having vision between 6/60 to 3/60, it's known as economically blind. That is category 2 blind. Anyone having vision between 3/60 to 1/60, it's socially blind. 1/60 to perception of light. कि light तो दिख रहा है. If you are putting a torch, तो torch में light तो दिख रहा है, something light. तो perception है कि नहीं है? That is manifest blind. और perception भी नहीं है, it's absolute blind, complete blind. So blinds have the category 1, 2, 3, 4, 5. How many of you know this classification? I guess this is more important in your ophthalmology. Perception of light, PLS, perception of light. How many of you know this classification? How to write this classification? The visual acuity you have to see. The visual acuity is 6/18 to 6/60. 6/60 to 3/60. Okay, am I right now? So 6/18 to 3/60, 3/60 to So यहाँ पे cat 1, cat 2, this is low vision. This is not blind. And from here the blindness is starting. From here the blindness is starting. How many of you know this? Can I proceed? Please learn this classification. It's very important. Okay. Most common cause I already told you. Vision 2020 we are going to cover in National Health Program. That's it. We are done with non-communicable disease. We can skip it. Okay. So we are done with this unit also. I will share the questions. Please solve the questions by yourself. And now I am starting healthcare in India. It's also a very small chapter. Hardly it will take 20-30 minutes. And after that, the last chapter, National Health Programs. So let's start healthcare in India. Okay, can I start healthcare in India? So in healthcare in India, I would like to first teach you various committees. There are various committees are there. Okay, committees we will take in the end. Just a second. Okay, just a second. I will take the committees in the end of this. First, let me tell you healthcare of the community. In the healthcare of the community, have you heard about this term, primary healthcare? What is primary healthcare? What is the care? What is this care about? Primary healthcare. The definition of primary healthcare is given by Alma Ata Conference. It was a conference which was held in USSR in 1978, where various countries have participated in this conference, and they have given the definition of primary health care. PHC is primary health center, Leah. I'm not talking about primary health center. I'm talking about primary health care, which is provided at primary health center. At PHC, the care we provide at PHC is primary health care. So what is this care? So it is a care which is given to the patient. It is based on practical and scientifically sound and socially accepted methods. So it is a care which is very practical. It is based on the scientific knowledge, and it is based on the acceptable, socially acceptable methods and technologies. It is universally accessible to all the individuals of this world and their families, in the community. And their participation is important, and it should be very affordable. All the person should afford it. Poor people should also afford it. So such a care is known as primary health care. Don't learn, just understand. It should be affordable, not very costly. It should be accessible. Everyone can get it. It should be within access. It should be practical. It should be scientifically proven, and it should be socially accepted. And full participation is important. I will explain you the meaning of the full participation. Such a care is known as primary health care. How many of you got it? So this care is known as primary health care. The definition of the primary health care. There are 4 principles. There are 4 hallmarks, and there are 8 elements of primary health care. So let me tell you 4 principles. The 4th principle is equitable distribution. It is not the thing the people who are living in cities, the urban people should get good care, and the people who are living in rural area, the villages, should not get the good care. Health is the right of everyone. If anyone is not good in health, anyone is having some disease, the person should have a primary health care. All the person, whether the person is urban, rural, rich, poor, whatever is the person. So equitable distribution of the primary health care should be there. Number 1. Number 2, it should be community participation. What do you mean by community participation? It is not the thing we are providing the care, but people are not ready to accept it. For example, take an example of contraception. We realize that it's a time. Yesterday I taught you demography. It's a time to reduce the birth rate. We have reduced the death rate drastically. Death rate is very much reduced. Nowadays our death rate is hardly 6. There is no much scope to reduce it more. So we have already done very discoveries and good healthcare services, and everything is good. Now it's time to reduce the birth rate so that we can equalize it, and the India can enter from stage 3 to stage 4. Yesterday I taught you. So I want to reduce the birth rate. For that, contraception is required. So I want that couples should use the contraception during sexual intercourse, but they don't know about contraception. Ki bhai hota kya, unko pata hi nahi hai, and they don't have any availability, especially in the villages. So in the villages, we have made all the contraception, all the types which I taught you yesterday, they all are available. The condoms are available, female diaphragms are available, OCPs are available, IUCDs is available, the terminal techniques, that is vasectomy and tubectomy also available. So we have made them available, but people are not using it. They are not participating. Participation is 0. So it is the necessity. It is not necessary only the availability should be there. Bhai, availability to hai, but they are not participating. They are not consuming it. Participation is important. One more example. This is the one example I have given, contraception. The second example is the toilets. Have you heard about open defecation? The main problem in villages in India. Have you heard about open defecation? Open defecation is a very big problem in India, in the rural areas especially. People don't have toilets at their home. That's why they used to do the open defecation, which causes many infectious diseases because of the open defecation. The sanitation is not very good. Contamination of food and water is very there, and foodborne diseases occurs very commonly in such places. So we do not want open defecation. So the government realized that people don't have money to build toilets in their homes, in the villages. So they sanctioned funds. So crores of funds was sanctioned. So all the people who are residing in the villages, to each home, government has provided sanctioned a fixed amount of funding, so that they should build a toilet at their home, and they stop open defecation and they start using the closed toilets. You may have seen the movies also, but this was a big scam. You know what was the scam? So the people have taken the funds from the government, but they have not built the toilet at their home because they are comfortable in open defecation only. They don't realize that it's a trouble. They find it's comfortable. Hana. So it's the problem of the government. It's the problem of the healthcare system, which is feeling that there is a problem. People are not feeling that's the problem. So they have taken the funds also, and they have not established the toilets at their home. So that is the community participation is important. How many of you got it? How many of you got it? That is community participation is important. We are providing the services, but providation is not only, availability is not only important. Participation is more important. That is second thing. Yes, vaccination also, Elizabeth, you can see. The third is intersectoral coordination. All the things should be connected. It's not you are concerned only with the treatment of the diseases. So being a doctor, the mentality occurs like, I want to treat my patients. That's it. No, prevention is also important. Hana, you should look about the nutrition of your patient. You should look about the water of your patient. You should look about the so everything should be there. Intersectoral coordination should be there, and appropriate technology. So tell me the 4 principles of primary healthcare. What is primary healthcare? Who has given the definition? Alma Ata Conference. It was a conference in which multiple countries participated at USSR in 1978. The conference was held, and multiple countries together defined the health definition. Such a health which is affordable, which is practical, which is scientifically proven, which is acceptable, and with community participation, full participation of the community. This care is known as primary health care. There are four principles. Equitable distribution, matlab rural is equal to urban. Community participation, intersectoral coordination, and appropriate technology. Okay, can we go ahead? Say yes. So equitable distribution, that is rural and urban. Community participation, placing people's health in people's hand. This is the punchline we use. Community participation should be there. Anna, community participation should be there. Okay, and intersectoral coordination. Anna, multiple sectors should be coordinated like agriculture, animal husbandry, food industry, and appropriate technology. Okay, what are the 4 hallmarks? AAAA. The health should be affordable. Affordable matlab it should be cheap. It should not be expensive, so poor can also afford it. Poor people, they don't have money, so but they can also afford it. Acceptable. Acceptable means people should be able to accept it. It should not be very embarrassing something. Hana, it should be acceptable to the people. Accessible. Accessible means people can reach there. Just suppose there is a village. So this is a village. So if you want to create a PHC, it should be close or within the village. If you're creating a PHC which is 100 kilometers away, so it's not within the reach. Now people will not go traveling so much of distance, and they will take the advantage of that. No. So it should be within the reach of the people, and it should be available. Hana, the doctors should be available inside that. The staff should be available. The medicine should be available. So availability is an issue. So affordable, accessible, acceptable, and available. Say it out. You can understand the meaning of all of them. Hana. So that is the 4 hallmark. Now come on the elements of primary healthcare. Elements matlab function. So I taught you 4 hallmark. I taught you 4 principles. These are the 4 principles. You get many questions on that. Which of the following is a principle, not a principle? Which of the following is a hallmark, not a hallmark of primary healthcare? Now I'm teaching you 8 elements. Last thing, I'm teaching you 8 elements. Elements are the function of PHC, function of primary healthcare. Hana? So it should provide, not just suppose there is a primary healthcare and you are a doctor at the primary healthcare. You are the doctor, the head, Hana, the medical officer there. You are the head of entire PHC. The male health worker, the female health worker, everyone is working under you. The ASHA, Hana, everyone is working under you. So what are the functions? Number 1, education. The mnemonic is elements itself. ELEMENTS. The mnemonic is elements itself. E stand for education. L stand for locally endemic disease ka prevention and control. ठीक है? E for essential drugs. The drugs should be present in PHC. Okay, number 1, education. You should concern with the education also. Education of the village people. Okay, locally diseases, endemic disease should be prevented. Essential drugs should be present. Maternal and child healthcare services should be provided, including family planning services. So at PHCs, the contraceptions are also available. Condoms are available. OCP is available. IUCD is available. Hana? Maternal health, child health, all the things should be available. E matlab immunization. Immunization. N for nutrition. T for treatment of the diseases. And S for safe water. S for safe water. So in all villages, there is a well. So chlorination of the well. The well has to be chlorinated. Chlorine. So it is also responsibility of the primary health care. Anna, so these are the 8 elements or the functions. How many of you got it? Okay, so please learn what is primary health care. You should know the definition of primary health care. You should know the hallmarks, not hallmarks. You should know the principle. You should know the 4 hallmarks, 4 principle, 4 hallmark, and functions or elements. Elements or functions, the 8 elements or functions. Hana, so please make the mnemonic and learn it. Hallmark are very easy, A. Elements are also very easy. The mnemonic is elements itself. Okay, and 4 principles you have to learn. Hana, equitable distribution, intersectoral coordination, community participation, and one more. So you have to learn that. So this is how we have completed primary health care. How many of you are with me? The last thing which I would like to tell you here is the level of primary healthcare systems in India. What are the levels, various levels of primary healthcare system? There are 3 levels. Anna, listen, the primary level, secondary level, tertiary level. So this is a village. This is a village. The people here are ill. Imagine some people have disease. So where they come? The first point of contact, either they will come to a sub-center or they will come to a primary health center. So sub-center and primary health center are primary level. If they are treated here, it's good. If not treated, they have something more serious, they are referred. They are referred to CHC. They are referred to CHC and district hospital. And if they are treated here, it's good. If they are not treated here, they are again referred. They are referred to the tertiary care, that is medical colleges, in which super specialty is also there. Anna, at PSC, we have simple MBBS doctor. See the degree, only MBBS doctor. At CHC, we have MD and MS doctors of few branches, not all 19. Hana, we have surgeon, we have pediatrician, we have obstetrician, we have medicine wala. Hana, we have a dentist also, but not all. Hana, ophthalmologist is also there, but not all. Okay, not all 19. Okay, in medical colleges, we have all 19 branches of MD, MS. Not only this, we have DM and super specialty doctors also. Got my point? How many of you got it? So that is the tertiary unit, right? The tertiary unit, the last referral. So you tell me, what is the first point of contact? The first point of contact with the patient is primary, Hana, the primary contact. That is PHC and subcenter. Hana, this is the first referral. This is the second referral. So this is how you have to learn. This is a system. So levels of primary health care. So government has decided that we will provide a care to our people. The government of India, along with many other countries, with WHO, they have decided that we will provide primary health care to all the Indians, to all the people who reside in India. Such a care which is very affordable, such a care which is accessible, which is available, which is very cheap, which is scientifically proven, and such a care we are going to provide to everyone. How? What is the infrastructure? How you will provide? So we have 3 levels. We have created a 3-tier system. The first tier is primary level. At the primary level, this is the first level of contact between the people and the healthcare system. So it is primary health center, PHC, sub-center, and village health unit. Village health unit is also there. So village health unit, sub-center, and PHC will come here. The secondary level of care is the first referral. If patients are not treated here, they are referred. Referred where? At CHC and district hospital. So CHC and district hospital will come here. This is first referral. If they are treated here, it's good. If they are not treated, they are further referred to tertiary level. This is the second or the highest referral. It is medical colleges and hospital where not only MD, MS, the super specialty is also available. Hana? The super specialty is also available. Okay? Got it? Got it? Can we go ahead? So this is the 3-tier system. Primary healthcare, secondary healthcare, tertiary healthcare. Primary healthcare include village health unit, sub-center, and PHC. Secondary healthcare includes CHC and district hospital. And tertiary healthcare finally included teaching hospitals, the medical colleges. Okay, so we will see their details one by one. Let's start with sub-center. First, I will teach you sub-center, then primary healthcare, then secondary community health center, that is CHC. So at sub-center, there are 2 types of sub-centers, sub-center A, sub-center B. In sub-center A, three staff is there. In sub-center B, 4 staff. Sub-center don't have any doctor. Sub-center don't have any doctor. Hana? In sub-center, basic care is given. Very basic, like ORS is available, basic things are available. Hana? Very basic care. Here only there is 1 female worker. 1 female worker, 1 male worker, and 1 part-time Safai Karmchari. Only 3 people are there. There is no doctor. Okay. At subcenter B, there are 2 females. Instead of 1 female worker, 2 female health workers are there. Male is still 1 and Safai Karmchari is there. So total 4 are there. Because at subcenter A, only services are there, but deliveries are not done. At subcenter B, along with the services, there is also a facility of the delivery. There is also a facility of the delivery. Vagina delivery, not cesarean section. So coming on primary health center, subcenter is done. Primary health center are also of 2 types, type A, type B. What is type A? So at primary health center, deliveries are done. Less than 20 deliveries in a month is type A. More than 20 deliveries in a month, that is type B. So type A, type B. You can see the staff. कौन-कौन होता है? Primary health center पे कौन-कौन होता है? So there is a medical officer who is MBBS, who is the head of the team, who is the head of everyone who is there at PHC. The doctor, the MBBS doctor. It's not MD, it's not MS. It's simple bachelor degree. है ना? Ayush is proposed. You may be knowing this news, na? The government is proposing Ayush at the village, but there is much protest in that. Many people are protesting. Ayush, you know, na? Ayurved, Unani, I told you, yoga, Siddha, and homeopath. So these doctors can also go and remain in the PHC, and they can look in the patients, because the MBBS doctors are not willing to go in the villages and give their services. Now that's why government is proposing to send the Ayush doctors there. You know this news, huh? But it is proposed, it's not confirmed yet. Apart from that, there is a data entry operator, with a system. He will be having a computer in which he will do the, I don't know whether the computer will be there or he will be doing the manual entries in the notebook. So there is a data entry operator. There is a pharmacist, 1 pharmacist. There is a nurse midwife, staff nurse, 3 staff nurse. There is a female worker, 1, male assistant, 1, health assistant female, that is 1, okay, lab technician, 1, okay, multi-skill group D worker. Group D worker, you know what a group D worker, the ward boys and all. So there are 2 ward boys and all. Sanitary worker and the watchman. The same person is a sanitary worker and the watchman, that is 1. Total 13. Total 13. And we have proposed at many places. So we want 18, but currently it's 13. So 13, and here we have 14. Here we have 14. That's it. So 13 and 14. That's it. We can see in type 1, type 2. This is the first point of contact between the people and the healthcare service. Okay, got it. Can we go ahead? The medical officer is the leader of the PHC. In PHC, there are 4 to 6 beds. How many beds are there? 4 to 6 beds are there. The next is the CHC. CHC. This is the staff written in front of you. So there is a medical officer. There is a medical superintendent. There is a public health specialist. There is 1 physician who is MD. There is 1 surgeon who is MS. There is 1 obstetrician who is MS. There is 1 pediatrician who is MD. अब सर्जन है तो सर्जन बिना एनेस्थीसिया के तो सर्जरी नहीं करेगा. So there is anesthetologist, है ना? There is 1 anesthetologist, okay, that is MD. 1 dentist is also there, है ना? BDS doctor, 1 BDS doctor. 2 general duty medical officer, the MBBS doctor. 1 Ayush doctor. 1 ophthalmologist who is having MS in ophthalmology. 1 nurse and 10 other staff nurses, है ना? And that's it. So this is the complete staff of CHC. Don't learn for your knowledge, I'm telling you. Okay, got my point? Under 1 CHC, 4 PHCs come. Under 1 PHC, 6 subcenter come. So सबसे पहले है subcenter, है ना? 6 subcenter के ऊपर 1 PHC है. 1 PHC over 6 subcenter. और 4 PHC के ऊपर 1 CHC है. 1 CHC over 4 PHC. How many of you got it? So you have to learn all this. Okay, got it? Say yes or no. These are the population norms you have to learn. You have to learn. There is no choice. You have to learn. Listen, subcenter, PHC, CHC. We are done with all 3. Compare it. Compare it. We have seen subcenter 2 type AB. We have seen PHC 2 type AB, but CHC don't have any further type. So can I say subcenter and PHC is the primary level of the care, and CHC is the secondary level of care? I told you, the PHC. This is in plains and this is in hilly area. In plains, we require every 5,000 population, there should be a 1 subcenter. But in hilly area, we require every 3,000 of the population, there should be 1 subcenter. Because in hilly areas or tribal areas, we want at more frequency. Got it? So normally in plains, we want 1 subcenter every 5,000 of population. But in hilly or tribal area, every 3,000. Now what I taught you, into 6 into 6. I taught you 6 subcenter, 1 PHC के अंदर आते हैं. Have I taught you this or not? 6 सब सेंटर एक पीएससी के अंडर आते हैं. So 5 into 6 is I guess 30,000, है ना? So over 30,000 और 6 into 3 वैसे तो 18 होता है, but make it 20. So 30,000 and 20,000. In the plains it's 30,000. In hilly area it's 20,000. Say yes. Got it? Got it? And make it 4. है ना? Into 4 times. I told you एक CHC में 4 PHCs आते हैं. So 3 into 4, 1,20,000. 20 into 4, it will be 80,000. So how many of you learned it? You get many questions on that. What is the staff? At subcenter, we have 3 staff. 1 male worker, 1 female worker, 1 safai karmi. है ना? Or 4 staff in type B. Here we have 13. And here we have 46. Please learn it. Subcenter is under central government. But PHC and CHC are under state government. How many of you got it? Respond, people, respond. Very important. So I taught you 3 things here. What 3 things I taught you? I taught you subcenter. I taught you PHC. I taught you CHC. Okay, G. Subcenter, PHC, and CHC. I taught you. I know. You tell me the level of the care. So you will say, ma'am, this is primary, this is primary, this is secondary. Okay, you tell me the number over how many population norms. So tell me the population norms in plains and tell me the population norms in tribal or hilly area. You get definitely question from this. Very important. In the plains, it's 5,000 and 3,000. Here I will say 30,000 into 6 कर दिया मैंने यहाँ, and 30,000 and 20,000. है ना? और यहाँ पे into 4 कर दूंगी मैं. So 1,20,000 and it will be 80,000. Let me write. Here I do into 6 into 6 into 4 into 4 because 1 PHC over 4 subcenter and 1 CHC. I'm sorry, 1 PHC over 6 subcenter and 1 CHC over 4 subcenter. How many of you got it? Please learn it. If you got it, it's good. If you didn't got, learn it. Please learn it. Please. I request you to learn these figures. You definitely get questions from them. And tell me the staff. Here total 3 staff are there. Here 13 is there. Here 42 is there on an average. This is under central government. This is under state government. This is under state government. This is the summary. This is the gist. Please learn the 3-tier system I'm talking about. Okay. Got it? Now job responsibility of a male worker and the job responsibility of a female worker. I'm not reading it, but you just read it for your own. है ना? Female क्या करेगी? Female will maintain the register of pregnancy. Female will take care of the family planning unit. Maintain the eligible. I told you yesterday who is the eligible couple. The wife is in the reproductive age. Eligible couple register maintain करेगी, है ना? MTP के records को maintain करेगी. Nutrition का ध्यान रखेगी, है ना? Iron folic acid tablets will be given, distributed. Immunization, TT in the pregnancy, है ना? दाई की training करेगी. She will train the दाई. You will train her and she will train दाईs, है ना? दाईs for the home delivery. Communicable diseases को notify करेगी. Vital events का record maintain करेगी. The birth and the death, है ना? रिकॉर्ड कीपिंग का काम है. ट्रीटमेंट ऑफ माइनर डिजीजेस लाइक डायरिया वायरिया में ORS यही दे देगी, आपकी जरूरत नहीं है. एंड टीम की एक्टिविटीज का ध्यान रखेगी. सो शी इज फीमेल. मेल वर्कर को सब घूमने वाले दो. रिकॉर्ड तो ये भी मेंटेन करेगा. देयर आर सम एक्टिविटीज विच आर कॉमन. लेकिन मलेरिया की स्लाइड घर घर जाके कलेक्ट करना वो फीमेल नहीं करेगी. द मेल विल गो हाउस टू हाउस एंड कलेक्ट द स्लाइड्स फॉर द मलेरिया, है ना? सो दिस विल बी डन बाय द मेल. ओके. So like, and the same, identify and suspect leprosy, TB cases, sputum collection, chlorination of the water. अब well कहाँ पे है? Village में well होगा ना, तो well पे जाके उसमें chlorination करना ये female नहीं करेगी, male worker करेगा. So there are some responsibilities of the female, some of the male, and you are the head of both. So you will assign their responsibilities. You have to do this, you have to do this, and you have to keep a check on them. You have to keep a check on them that whether they are doing their responsibilities regularly or not regularly. Got it? This is the thing. So that's all about it. That's all. Read the question, tell me the answer. 1 PHC is located over how many population? How much population? I'm mentioning nothing. So I'm asking for plains. If I mention nothing, I'm asking for plains. Can you please tell me? What is the correct answer? What is the correct answer, people? Yes, PHC I'm asking now. Answer is 30,000. And if I include in the hilly area, then answer will become 20,000. Then in that case, answer will become 20,000. If instead of PHC, if I say subcenter, answer will become 5,000. Likewise, we change the question, the answer changes. Read the question. A subcenter in hilly area. Please read it very carefully. A subcenter in hilly area over how much population? Every 1,000, every 2,000, every 3,000, or every 5,000? What's the correct answer? A subcenter in a hilly area. It's over 3,000. Hana? And if I remove the hilly area and do it in plains, the same question will become 5,000. Hana? So 3,000 and 5,000. Learn the two figures for subcenter. Learn the two figures. Which of the following is not a work of female worker, female healthcare worker, not a work of the female worker? Malaria surveillance, distribution of condoms, immunization, or dots activity? What's the correct answer? Yes. Malaria surveillance is a work of the male worker, house to house slide collection for malaria. It is for male, not for the female. Rest of them can be done by female also. Contraception, she takes care of that. Okay, can we go ahead? The next question. CHC, Community Health Center, over how much population? If I'm mentioning nothing, I want to ask you in planes. Or both, there is a range. 40 to 60,000, 60 to 80,000, 80,000 to 1,20,000 or none. So it's 80,000 to 1,20,000. Basically, 80,000 is in hilly area and 1,20,000 is in plains. So both are given. The range is given to you, minimum and maximum. So you definitely get questions on that. We are done. We are done with this chapter also. Congratulations. Okay, you have to learn this list. You have to learn the first country to start the initiative. Do you know the first country to start family planning is India? The first country to start blindness program is India. The first country to launch ORS, low reduced osmolarity ORS. I told you, 245. Total is 245. I told you glucose is 75, sodium is 75, chloride is 65. Total was 245. It's new ORS, the reduced osmolarity ORS. It is also launched by India. The term pasteurization and germ theory, these were first launched in the France. Socialized medicine in Russia, and compulsory insurance, health insurance, it's in Germany. So learn, you get questions on them, especially in India. Please learn. India is the first country to start three things. Start family planning services, start blindness control program, and launch ORS. India is the first country. Okay, got it? India is the first country. Okay, these are the important days you have to learn in the end. I'm giving you, I'm not from January till December, the complete list is with you. In January, only one date is important, 30th January, Leprosy Day. In February, only one is important, 4th February, it's Cancer Day. On March, many 4 dates are there, which are important, March May. So March May, 6th March is Glaucoma Day, 8th March is Women Day. None of you celebrate that, I know. So 20th March is Oral Health Day. And 22nd March is Water Day. So this is how you have to learn. 7th April is Health Day, on which every year WHO give the theme, the new theme of that year. And 31st May is No Tobacco Day. Likewise, you have to learn the days. Please learn. 21st June is Yoga Day. 1st July is Doctor's Day. I guess everyone knows the 1st July, Doctor's Day. 11th July is Population Day. So please learn. Jitne bold mein question is already there on them. So breastfeeding week, I already taught you when I taught you breastfeeding. 1st to 7th August. Literacy Day, I already taught you when I taught you literacy rate in demography, 8th September. IDD, iodine deficiency disorder, it's 21st October. Immunization Day is on 10th November. Diabetes on 14th November. Polio Day is on 24th October. Please learn it, learn it. AIDS is on 1st December. AIDS Day is on 1st December. Got it? How many of you got it? Can we go ahead? So please learn it. We are done with this also. We are done with this also. Okay, so let's come finally now. Annotated PDF. Few students were asking now, so I will share the annotated PDF today. All the annotated PDF. Maybe all 16, 17 chapters, whatever I am teaching you. I will share annotated PDF today evening to you. I will share with the team, and they will share with you. Okay, Ji, I have saved them. Okay, Hana, the last chapter now. Finally, the last chapter, National Health Programs. Can we start National Health Programs now? Let's start National Health Programs, the last chapter. Maybe 1 hour or 1.5 hours. We will pack after that. If still after that you have any doubt, you think some topic is important and like that, then you can let me know. I will take it, Simran, I will take it. You want me to take the committees? I will take the committees first. I forgot to take. Thanks for reminding. Okay, let me come on the committees. Okay, these are the health committees. Just take the important point in them. So let me read the name of the committees, then I will tell you the important points in each of them. Bhor Committee, Mudliar Committee, Chaddha Committee, Mukherjee Committee, Junjulwala Committee, Kartar Singh, Srivastav Committee, Krishnan Committee, Bajaj Committee, Tendulkar Committee. They come in this sequence only. The first is the Bhor Committee. It lasts from 1946 onwards. 1946. After that, Mudliar came. आफ्टर दैट चड्ढा केम, है ना, मुडलियर सिर्फ एक साल के लिए आया 1962, उसके बाद चड्ढा टेक ओवर, चड्ढा इज 1963, आफ्टर दैट 1967. Then these are the health committees, and one by one a committee, the government is making a committee that takes care of the health of the country people. These are the name of the country communities given, one by one they are launched, है ना. 1967 Junjulwala, 1973 Kartar Singh, then Srivastav. Don't learn the year, learn them in a sequence, learn them in a sequence. Okay. Okay, so coming on the committees, the first committee I taught you is the Bhor Committee. Bhor Committee, also known as Health Survey and Developmental Committee. Don't learn the other name. इसने दो चीजें बोली, एक short term measure, एक long term measure. The first time Bhor Committee said that we should create a PHC every 40,000 population, but nowadays it is 30,000. We know, है ना, 30 and 20. First time they said we should have one PHC over 40,000 population. That is the short term goal, and with 2 medical officers. Okay, that is a short-term goal. It should be 30 bedded, but we now the PHCs are only 4 to 6 bed, and there should be 3 sub-centers under one PHC. But now there are 4 sub-centers. Everything is changed now. It was the first committee, जिसने first time हमको ये सब guidelines दिया. Right? The long term is the 3 million plan. What is the 3 million plan? There should be a primary health unit with 75 bedded hospital. एक 75 bedded hospital बनाना है. Okay, that is known as primary health unit. The secondary health unit बनाना है, which should be a 650 bedded hospital. एक regional health unit बनाना है, which should be a 250 bedded hospital. So that is 3 million plan. है ना? These were the proposition. Don't learn it. Just see ki, what you have to learn. The Bhor Committee have given 2 recommendations. What were the recommendation given by the Bhor Committee? We should make a PHC over 40,000 of population and the 3 million plan. In 3 million plan, there should be a primary health unit, secondary health unit, and regional health units are there. These are the bedded hospital. He has created social physicist. उसने promote किया कि in MBBS education, there should be 3-month posting in PSM. You have your postings in PSM? Do you have internship? You may have postings now. So you have in your entire curriculum, you may have 3-month training in PSM department. Then you are known as social physicist. If your 3-month training is over, now you, along with the doctor, you are social physician also. Social physician. He introduced this term. He has introduced the school health also. In the school, I told you, every 6 months, the free checkup of the eyes is done, the dental checkup is done. So that is school health. In the school health, free services is provided in the school people, the school children, I mean. So this concept is also given back. So 4 concepts he has given. So just learn the green I have highlighted. Bhor Committee. क्या दिया Bhor Committee ने? Number 1, PHC का concept. Number 2, 3 million plan. Number 3, social physician. And number 4, school health. How many of you got it? Please learn that. है ना? Learn it. You don't have to understand much. Just learn कि ये सब इसके recommendation है. उसके बाद next committee आई Mudliar Committee. Mudliar Committee, उसने कहा 1 PHC per 40,000 population maximum, and he constituted All India Health Service. All India Health Service का constitution इसने किया. That's it. Not much contribution because it is only for 1 year. After that, it is replaced by the next committee, Chaddha Committee. This committee was dismissed and a new committee is formed by the government, the Health Committee. That is Chaddha. है ना? चड्ढा ने बहुत गड़बड़ किया. क्या गड़बड़ किया? है ना? We have two problems at that time. In 1963, we were facing 2 problems in India. Number 1, malaria. Malaria was a real, very big problem in India at that time. And number 2, family planning. Number 2 was the family planning. है ना? Family planning means contraception use has to be increased. So we have to aware more and more population, the eligible couples for the contraception use. So we were having different stuff. So we were having different staff working for that. But he has linked the 2. He has said there should be only 1. उसने cost cutting किया. उसने बोला एक ही basic health worker रख लो PHC पे. एक ही basic health worker रख लो every 10,000 of the population, जो malaria vigilance भी करेगा और family planning का भी काम करेगा. है ना? So उसने गड़बड़ कर दिया. है ना? अब एक ही बंदा है. There is only 1 person who is taking care of both the programs. So family planning program is separate thing. Malaria control program is separate thing. Both are conducted at PSC. So there is only 1 worker, the basic healthcare worker who is taking care of the 2 things. So he has linked the 2 programs together. Which 2 program? Malaria and family planning. एट द एंड रिजल्ट क्या हुआ, ना तो ये अच्छे से हुआ ना तो ये, है ना. सो नाइदर वी फुलफिल्ड द गोल्स एंड टारगेट्स हियर, नाइदर वी फुलफिल्ड द गोल्स एंड टारगेट्स हियर, बिकॉज वी आर हैविंग ओनली वन बेसिक हेल्थ वर्कर. So that is Chadha. That was a flop show. That was a real flop show. Okay. So next committee is Mukherjee. Mukherjee has done the D-Link. What does the Mukherjee has done? D-Link. D-Link कर दिया वापस उसको. Malaria अलग, family planning अलग, different stuff. है ना? So they have again D-Linked. And separate staff for the family planning. Separate staff for malaria, separate staff for family planning. इन्होंने समझदारी की बात की. How many of you understand Hindi? हाँ, got it. So चड्ढा ने जो गड़बड़ किया उसको मुखर्जी ने सुधार दिया. है ना? लान शुरू से लान करो. भोर ने क्या किया? First, he introduced PHC, over 40,000 population. He has given 3 million plan. He has created social physician. Any MBBS doctor who is doing 3-month compulsory posting is known as social physician. Okay? And school health introduced kiya usne. The concept of school health. Mudliar have constituted All India Health Service. That's it. Chadha have linked the two things together. And Mukherjee have de-linked them. Mukherjee ne de-link kar diya. The two things are malaria and family planning. Are you people there? Reply, respond. The next is Jhunjhunwala. The next is Jhunjhunwala. इन्होंने क्या किया? इन्होंने बहुत अच्छी बातें की, है ना? I like their work. So what they have done? They have done unified cadre, common seniority, recognition of the extra qualification. If someone is extra qualified, we should recognize it. Equal pay for equal work, special pay for special work. And no private practice. They recommend कि इंडिया में private practice करना ही नहीं चाहिए डॉक्टर्स को. Doctors should not do private practice in India. Everyone should be in government practice only. Government hospitals should be very good. Equal work for equal pay, special work for special pay, and extra qualification recognition, common seniority, and good service. So all the things are very good. है ना? Ideally it should be followed, but it is not followed. है ना? So we have many things working here. है ना? So not equal work for equal pay, not special work for special pay. Even extra qualification is there, so they don't pay extra. They say you are all overqualified for the work. We don't require you, like that. So working environment for the doctors should be good, like that. So that is the Jhunjhunwala ke recommendations. After that आया Kartar Singh committee, है ना? So what he has done? Kartar Singh ने all the ANMs को replaced कर दिया female health worker से. Female health worker, the female health worker. Now there is only one female health worker, not multiple ANMs. Okay, all the malaria worker, vaccination worker, health education assistant, family planning worker, they all are replaced by male health worker. So at PHC we have one female worker, one male worker. है ना? The female worker, actually she was ANM, it is replaced by female worker. And male worker is, it can be malaria worker, vaccination worker, health education assistant worker, and family planning worker. उन सबको combine करके एक male worker बनाया. Kartar Singh recommended one PHC over 50,000 of the population, है ना? Over 15 to 16 sub-center, जो सब change हो गया है आज, है ना? And there should be a supervisor. This is male worker, female worker. They both have supervisor, male supervisor and female. So under one supervisor, there should be 3 to 4 workers. Under one female, 3 to 4 workers. है ना? The workers, the male health worker and female health worker, they are juniors. Over them, they have their supervisors. So male health supervisor, female health supervisor. Under each supervisor, there are 4 male worker, there are 4 female worker. है ना? Basically, male worker is a replacement of all the malaria worker, vaccination worker, education, family planning. They all are replaced by this. And all the ANMs are replaced by this. How many of you got it? How many of you? So this is Kartar Singh. Kartar Singh, one multi-purpose worker. It is known as one multi-purpose worker. The male, the female. Job responsibilities are different. So till date, we are following it. So that is Kartar Singh recommendation. The next is the Srivastav. Srivastav ne kya kiya? Srivastav have created bands of para-professional and semi-professional health workers within the committee. Okay. He has done the reorientation of medical education. Reorientation of medical education scheme, ROME. Nowadays, we are going from NEET PG towards next, na? So what basically we are doing? Next aane wala hai, everyone knows, है ना? We are doing the reorientation of complete medical education. We are reorienting it, है ना? So Srivastav ने जो तब recommend किया था, we are going to follow it. I don't know when, maybe in 2028 they are saying. So anyways, that is the reorientation of medical education. He proposed, है ना? And village health guide को first time इसने introduce किया, the scheme of village health guide. So please learn main contribution. Krishnan ने urban revamping किया, और Bajaj is not important. You can leave Bajaj. So we are done. We are done. So please learn the main contribution of the committees. These are the health committees the government appoints for 5 years. Before 5 years only, many of them get dismissed and new committee is formed. Say yes, people. Say yes. Read the question, tell me the answer. You people are alive? I mean, you are live. Read the question, tell me the answer. 3 million plan was proposed by, very commonly asked question. Is it Kartar Singh? Is it Mudliar? Is it Srivastav? Is it Bhor? Who has given the 3 million plan? Who has given the 3 million plan? Very important, 3 million plan. Don't learn the 3 million plan. He has said 3 types of hospitals to be created: the primary, the secondary, and the village hospitals. This is 750 bedded, this is something 650 bedded, I don't remember. This is 250 bedded. Don't learn how many bedded. It's a 3 million plan. That's it. Bhor committee. You all are right. Very good. Multi-purpose worker scheme in India was recommended by the best scheme. All females are replaced by female health worker. All males are replaced by male health worker, and they should have supervisors. So is it Srivastav, Bhor, Kartar Singh, or Mudliar? Who was an intelligent person? Which committee? Yes, Kartar Singh. Kartar Singh. He was very intelligent person, and I like his recommendation. Till date, it is followed. The multi-purpose worker. One female worker, one male worker. Okay. So correct answer is Kartar Singh. Okay. Integration of the health services was first proposed by. Integration of the health services. I forgot to tell you, it is Jhunjhunwala. जिसने integration of the health services किया. Multiple health services were integrated together. Concept of multi-purpose worker, I already told you, it's Kartar Singh. So I'm skipping, it's a repeat question. You get malaria and family planning linking and delinking also you have to learn. So Chadha has done the linking, and who has done the delinking? Chadha has done the linking, and Mukherjee has done the delinking. These two are also PYQs. So that's all about it. Got it? Who was asking? So this initial portion is also done. Okay, so these committees, you usually get questions on that. Not very important topic, but yeah, still, we have covered it. So can we start the national health programs now with your due permission? Can we start? Let's start it. Okay. Okay, so let's start national health programs. The important one only we will take here. So let's start first the maternal and child health care programs. Then we will come on adolescent program. First, we will see the maternal and child health care. Have you heard about RCH services, reproductive and maternal neonatal child health care services? It is known as RMNCHA. What is RMNCHA? Say R is reproductive services. We will provide reproductive services. M is maternal service. What is reproductive service? We will provide contraceptive to the couples. What is M? Maternal service. We will provide services, the antenatal care to the mother, the pregnant lady, I mean. N is neonatal. After the birth, we will take care of the neonate also. C is child. The neonate will convert into child while growing. And A is adolescence. So we are providing services to 5 people together. So it is the health service which I am providing to 5 people. A बाद में add हुआ है. पहले सिर्फ RMNC था, है ना? But बाद में A भी add हुआ. So it is after health. So we take care of health of five group: reproductive age group, maternal, neonatal, child, and adolescent. So this is RMNCHA. H is the health of whom? Health of reproductive age group. They will reproduce. The mother will become pregnant. I mean, the lady will become pregnant. That is maternal health. Then she will give birth to a child. That is neonate. The child will grow, and from neonate, it will convert into child. And later on, the child will convert into adolescence. And adolescents again reproduce. So it's a cycle. You can understand like that. I learned like that. So you can say RMNCHA. Say yes. So this is the services we provide. So it is having 5 into 5 matrix. What is 5 into 5 matrix? We are having 5 group. I told you what 5 group. Reproductive age group, what services we are providing? So we are providing 5 service to each of the group. Reproductive age group people, we are providing 5 services to them. Pregnant ladies, we are providing 5 services to them. Newborn, we are providing 5 services to them also. Children, again 5 services. Adolescents, teenage, we are providing 5. It is known as 5 into 5. I don't recommend you to learn all 5 into 5, but have a look. This is 5 into 5 matrix. So they give you a question, 5 into 5 matrix is seen, and you have to mark RMNCHA. This is 5 into 5 matrix. You got it? What are 5? 5 groups are in front of you, and 5 services to each of them. Say something now. So reproductive age group, what services we provide to reproductive age group? We provide contraceptive devices to them. Intrauterine contraceptive, postpartum contraceptive devices to them. IUCD we provide, number 1. Interval IUCD also we provide. Just after the delivery, we can insert IUCD, and after some time, interval IUCD also we can insert, free of cost. Home delivery of contraceptive. Asha will go door to door and provide condom and OCPs. For IUCD, they have to come and get inserted. It is not a home procedure. But OCPs, condoms can be given. Home delivery of the contraceptive we are doing. Asha is acting like Swiggy and she is giving it there. Hana? Home door to door. All the eligible couple register is there. Hana? So wherever there is an eligible couple, she can provide. Okay. Nishchay kits, the pregnancy kit. I have shown you the image yesterday. Now, Nishchay kit, the pregnancy. If any lady is doubtful whether she is pregnant or not, free pregnancy kit, urine pregnancy kit, UPT, is provided to her. And fifth, quality sterilization. If lady want to be permanently sterilized, not only lady, male or female, vasectomy, tubectomy, both services are provided. So these surgeries are free of cost. So these are the 5 services we provide to reproductive age group, the males and females, free of cost. To the mothers, the pregnant ladies, we provide maternal child tracking system, MCTS. You know what is MCTS? As soon as a delivery takes place, in the mobile there is an app. It is known as MCTS app. It is an app in which we do the entry of the mother, the mobile number of the mother, and all the details of the mother we fill, and the newborn also, all the details we will fill. So time to time there will be a SMS, free SMS or free calling services there. They will get the SMS whenever there is a time of vaccination. So it's a time for your baby to get vaccinated. This vaccine is pending, or Hindi mein they will get the messages like that. So they will come to know, we can track them. If they are not coming for the vaccination properly, there is an address, someone can visit, we can call and we can trace them. So it is a tracking system, the mother and child combo tracking system. It's like an app, and everything is software. So we can do so. Okay, high risk pregnancy, we will give special care, special tracking. Emergency obstetric care we provide. Okay, maternal death review. None of the mother in India should die. Mother means pregnant lady. If any mother, any pregnant lady dying during pregnancy at the time of delivery or within 42 days after the delivery as a complication of delivery, it should be reviewed. It should be proper review. It should be reason. A committee sits and they discuss you why this happened so that it doesn't happen again. Whose mistake was there? Why it happened? So there is a committee and it should be answerable. It should be answerable that why the death occurred. What was the reason of the death? And at what step we can avoid it so that from next time it shouldn't happen. And misoprostol, the emergency contraceptive. After sexual intercourse, if someone wants the contraception, the emergency contraception. So these are the 5... No, misoprostol is for abortion. If some lady wants the MTP, abortion, so misoprostol is for that. So these are the 5 free services to the mother. What are the 5 services to the newborn we provide? We provide the breastfeeding. The breastfeeding, I told you, the protocol, the 10 baby breastfeeding friendly initiative we have taken. So breastfeeding, home-based postnatal care, essential newborn care. There is ICU, sick newborn ICUs are there. And gentamicin is provided by the ANM if the child is sick, having diarrhea or having respiratory tract infection. So these are the newborn services. The child services, we take care of the nutrition, diarrhea management, pneumonia management, immunization, Rashtriya Bal Suraksha Karyakram. I will tell you what is it. And to the adolescent teenage pregnancy, we give them sex education, teenage pregnancy. It should be avoided. It should not be done. Like that. And community-based services, adolescent reproductive sexual health. Clinics are there. Weekly iron folic acid supplementation, menstrual hygiene. So all these information is given them. This is 5 into 5 matrix. I do not want you to learn it, but you have understood it's good. So you know the 5 groups and 5 into 5 matrix. Okay, so let's start with the maternal programs now. In the maternal programs, the first program I would like to tell you is the Janani Suraksha Yojana. Very, very important. I forgot to put the logo. Janani Suraksha Yojana. What is Janani? If you know Hindi, Janani is mother. Suraksha, protection. Yojana is a scheme. So it's a scheme in which we give protection to the pregnant ladies, the mothers. They are going to be mothers, the pregnant ladies. Now, how we want to protect the pregnant ladies? We do not want any of the pregnant ladies should die, either during pregnancy or during delivery or after delivery within 42 days. We do not want they should die. We do not want. We want to protect them. The government want to protect them. So we want institutional delivery. What do we want? We want institutional delivery. So maximum deliveries should take into the institutes only. But in India, especially in villages, home deliveries are very common. The senior female of the family, like the grandmothers and all, they just conduct the delivery. They know कि हमने तो 10 बच्चे पैदा किए. I know how to do it. Don't get admit in the hospital. It will be very costly. We cannot afford it. We will do home delivery. It's vaginal delivery. It will be automatically done. I mean, we will assist it. So the senior female only conduct it, and multiple senior females of the village, they just gather together and they just conduct the delivery. We do not want that. If it is a normal vaginal delivery, it's okay. But if it is some complication takes place at the time of the delivery, what they will do at that time. They are not prepared for that. है ना? So all the deliveries should be institutional. We want to do that. So how to do that? है ना? We are counseling them, come in the hospital, do delivery, it will be free of cost, come. They are not coming. It's very difficult. It's very difficult to change someone's mentality. Opinion can be changed. Behavior can also be changed. But actually, it is converted into action is very difficult. The last step is very difficult. Anna, you can change someone's opinion by giving a good speech, by telling them the facts. You can change someone's behavior also. But converting into action, what you are saying, they should convert into action. The last step, they are convinced. They will agree with you. Yes, you are right. You are right. But they will not do that. Hana, it requires a very high degree of motivation. Hana, especially in the village people where they are not very educated. So it's very difficult with them. You got my point? So what we have done, see what government has done. Government has launched Asha, Hana, and we asked Asha, we will give you a fixed salary. Your fixed salary is fixed, whatever we will give you, that is the fixed salary. Along with that, we will give you incentives. Incentives are extra payment. Along with the fixed salary, you will get extra payment for what? Hana, based on what? How much? How many? Now, Asha is for one village. For one village, there is one Asha. Hana. So in your village, how many females get pregnant? Whosoever female get pregnant in your village, in Asha's village, she, during the 9 months of pregnancy, she has to counsel that lady, go and counsel in the local language that you have to do institutional delivery. If we will go, we cannot counsel the village people very good. Sometimes we don't know their language. We don't know how to talk. So Asha is among them only. Asha is the lady from the village only. Hana, she know how to counsel her people, her village people, I mean. So she will counsel this lady that we will do an institutional delivery only. Why? So she will attract the mother, attract the pregnant lady, that you will get money, the cash money, if you do the institutional delivery. So the government is offering money to the mother also, to Asha also, as a package we are giving. So let's see Janani Suraksha Yojana. In the rural area, it's more required. In urban area, it's not very much required, because in urban area, people are already aware. Hardly any home deliveries takes place. Maximum deliveries are automatically institutional. So rural area, urban area. Okay. In each of them, there are two types of states: low performing state, high performing state. So out of total states in India, how many states are there in India? Government has divided the states into two parts. Some states are low performing, some are high performing. Kerala is there, Punjab is there. In low performing, maybe Uttar Pradesh, Madhya Pradesh, maybe, based on their IMR and maternal mortality rate. The states in which maternal mortality is high, they are low performing. The states in which maternal mortality is very low, hardly negligible, they are high performing state. So based on that we have. So main it is required in low performing states. In high performing states, it's not required. Got it? Not very much required. Got it? Say yes. Say. So see, government is giving a total package of 2,000 and 1,300 in the rural areas. For low performing states, it's 2,000 package. And for high performing states, it's 1,300 package. Out of this package, 600 is given to the Asha. Asha's cut is fixed, that I will take 600 per delivery. है ना, 600 per delivery. This is Asha's cut. The remaining will be given to the mother for doing institutional delivery. So out of 2,600 minus हो गया तो कितना बचा? 1,400. And out of 1,300, 600 minus हो गया तो 700. So please learn. So government is giving a total package of 2,000 and 1,300. Out of 2,600 given to the Asha and 1,400 given to the mother. For what? For mother is given what do you say, the money for doing institutional delivery, and Asha is given the money for taking the mother to institutional delivery. She is supporting her now, she is convincing her. So this is incentive based. Got it? So your mother's package is given to mother's account only. It is not the husband's account. She should have her own account in the bank. It will be given in the bank, not cash. And Asha is given to Asha. Got it? This is how we do. Say yes. Asha को भी 600 पूरे नहीं मिलेंगे. 600 में से we divide it into two parts, 300, 300. 300 for the antenatal component and 300 for institutional delivery. Throughout the 9 months, Asha should do the antenatal component. She should give the 2 doses of tetanus vaccine. She should give the iron. She should do the deworming. She should do everything. Then 300 is given. And then institutional delivery, again 300 is given. So total 600. This is how government is attracting for institutional delivery. This is for rural area. Come on urban area. In the urban area, see the total package. Here the total package is 1,400 and 1,000 only. Because in urban, it's not required. That's why package is very low. People are already aware. Again, but in urban, 1,400 and 1,000, the Asha's package is 400. It's fixed. So 1,400 minus 400, it's 1,000. And 1,000 minus 400, it's 600. Say, people say. So 400 में से भी 200 आशा को antenatal postnatal. How many of you got it? Janani Suraksha Yojana. You get many questions out of that. Janani Suraksha Yojana. है ना? So tell me how to draw it. How to draw it? So say, ma'am, rural. Okay, rural and urban. The first thing. ठीक है? Rural and urban. Here also low performing state, high performing state. And here also we have low performing state, high performing state. We make a 2 by 2 table. So divide them in 3, 3, 3 column now. Listen, the mother package, the Asha package. यहाँ कहाँ लिख दिया मैंने? Yes. So I want to say mother package, Asha package, and total package. Here also mother package, Asha package, and total package. How I learn? I learn total. I learn total. I don't learn mother and Asha. I learn total. So I learn like 2000. I learn like 1300. I learn like 1400, and I learn like 1000. That's it. And I know Asha's cut is fixed. In rural area, it's 600. And in urban area, it's 400. Whatever is the pending is given to the mother. So mother will get here, I guess, 1400. Here the mother will get 700. Here the mother will get 600. And here, no, not 600. It's 800. Shares of that, no, 1000. And here the mother will get 600. Whatever is getting the mother. That's it. This is how we learn. People respond here. Come on, got it. This is Janani Suraksha Yojana. I tried hard to explain you. This is Janani Suraksha Yojana. अच्छे अच्छों को समझ में नहीं आता. Okay, this is Janani Suraksha Yojana. Learn that. The next is the Vande Mataram scheme. What is Vande Mataram scheme? In Vande Mataram scheme, it is launched for providing safe motherhood service. Now, do you have a nursing home? Are you a lady doctor? Do you have a maternity home? Are you a OBG specialist? Or you are a simply MBBS doctor? It is a voluntary scheme. You can opt for Vande Mataram to the government. There is a website, you can apply it, that I want to participate in Vande Mataram scheme, or I want to enroll that. So the government will provide free of cost iron folic acid tablets, OCPs, and TT injections. It will provide it at your clinic free of cost because you have enrolled here. So all the females coming to you, you should also provide them free of cost. You are just a mediator taking from the government and providing it to their patients, not patients, the pregnant ladies. So that is via multiple persons who are enrolling in Vande Mataram scheme. The government is distributing the iron folic acid tablets, OCPs, and TT injections to the pregnant ladies. We want all the pregnant ladies should get all three. OCP is not required during pregnancy. OCP is required for the reproductive age group. IFA is required for adolescence also, IFA is required for pregnancy also, and TT is given during pregnancy. So these are the things given to you. Okay, so this is a voluntary scheme. Anyone can participate. If you wish, you can also participate. The next is Pradhan Mantri Matra Vandana Yojana. Pradhan Mantri Matra Vandana Yojana. You can see there is a mother and there is a kid. This is the logo. Pradhan Mantri Matra Vandana Yojana, also known as maternity benefit scheme, also known as pregnancy aid yojana. So here a cash benefit, not an account, directly cash. A cash benefit of 5,000 is given for the first delivery. But that too in 3 installments, directly nahi. This is by Women and Child Development Ministry, it is given. Okay, so the first installment when the pregnancy is registered. The first pregnancy, there is a lady who becomes pregnant first time. So she has to come to the sub-center and get it registered. She will get 1,000 rupees for that. At least 1 antenatal checkup. Minimum 3 are required. But at least 1 antenatal checkup she is doing after 6 months of the pregnancy, during the 3rd trimester. So she will get additional 2,000. And after the childbirth is also registered. And child has received BCG, OPV, DPT, and hepatitis B. The 4 vaccines are given to the child. She will get additional 2,000. So see how government is giving more and more cash benefits and incentives to the mothers so that all these targets are fulfilled. So this is known as Pradhan Mantri Matra Vandana Yojana, in which the government is giving a cash benefit of 5,000 on the first delivery to the ladies who live in rural area or any ladies. Number 1, it is in 3 installment. Ek saath nahi 5,000 milenge. Only in first delivery. It is not the ladies becoming pregnant again and again to take the 5,000. It's only for first delivery. The delivery should be registered, number 1. Number 2, during the 3rd trimester, there should be 1 antenatal visit. And number 3, the childbirth should be registered. And child should get the basic vaccination. So that is 2000 again. How many of you got it? This is the Pradhan Mantri Matra Vandana Yojana, PMMVY. Okay. The next is Janani Sishu Suraksha Karikram. This is not Janani Suraksha Yojana. Hana, along with the Janani, we are taking care of Shishu also. Who is Shishu? The newborn. The newborn is Shishu. The Janani is the pregnant lady. So we want to take care of pregnant lady. Not only this, we want to take care of the neonates also. The pregnant ladies as well as neonates. दोनों को हमें देना है ना? So beneficiary, the pregnant ladies. Who are the beneficiary? Okay, all the pregnant ladies are there, है ना? Along with during delivery. Just a second. All the pregnant ladies, all the deliveries who are in labor, who are delivering, है ना? They are also beneficiary. Post delivery till 42 days, the ladies can claim this Karikram, and the infants up to 1 year of age. These are the beneficiaries. है ना? The punchline is that it should be zero out of pocket expenditure. Zero out of pocket. There will be zero expenditure in the entire pregnancy. है ना? So all the care will be given by the government. है ना? Rather, at the time of the labor pain, the free pickup and drop will be provided by the government only. So ambulance will come, free pickup will be there, and after the delivery, free drop will be there, institutional delivery. All the medicines, all the diagnostic thing, all the things of the newborn, everything will be free of cost. It is known as zero out of pocket expenditure. So that is Janani Sishu Suraksha Karikram. Hana, this is the logo. You can see Janani and Sishu. So we can go ahead. Hana? So that is the thing. The next is Suman. What is Suman? So read these full forms here. It's very tedious. Hana? Surakshit Matritva Ashvasan. Surakshit Matratva. Matratva. Okay. M is Matratva and AN is Ashvasan. Surakshit Matratva Ashvasan. Hana? How many of you don't know Hindi? Anyone who don't know Hindi, so it's out of your scope. Even who knows Hindi, it's difficult for them also to learn. So such a pure Hindi. How many of you don't know Hindi? Huh? It is Suman. है ना? So Surakshit Matritva Ashvasan. So what is the aim? The aim is assured, dignified, respectful, quality health care at no cost. At zero cost, we should provide a assured care, a dignified care, a respectful care, and a quality health care to all the pregnant ladies with zero tolerance of denial of the service. If anyone who is not doing the service normally, any nurse, any doctor, there is zero tolerance for that. Hana? And of all preventable maternal and newborn death, we do not want in the country, none of the mothers should die. No, during pregnancy, if any mother is dying now, it's a very bad thing. Means the healthcare service of your country is the worst. Mother should not die. Hana? During pregnancy, at the time of the delivery and within 42 days. No. And there should be no newborn death. There should be no. So we want that. We want to end all preventable cause and provide a positive birth giving experience, positive birthing experience to the mother. We want to provide that. This is Suman. This is Suman. Hana? So you have to just learn all the pregnant ladies, all the mothers up to 6 months post-delivery, and all the sick newborns are the beneficiary. The next is Pradhan Mantri Surakshit Matritva Yojana. Pradhan Mantri Surakshit Matritva Yojana. You can see. So 9th of every month. I mean 9th January, 9th February, 9th March, 9th April, 9th May, 9th June, July, August, September, October, November, December. 9th of every month. 9th Tariq is fixed in 14 states, not the entire country. Free health care will be given to all pregnant ladies, even in private hospitals, not only in government. Hana? So the poor lady who is pregnant coming to a private practitioner also on the 9th of every month, the private practitioner cannot deny and cannot take the fees. Hana? So she's coming on the 9th of the month, and that is under the program. So 9th June ko ye launch hua tha. So free treatment is given to her, to the poor pregnant lady. You got it? So Pradhan Mantri Surakshit Matritva Yojana. So if you are a gynecologist, OBG, and you are practicing private, not in a government hospital, you take fees, of course, from your patients, not patients, the pregnant ladies. So you take the fees. But any lady who's coming on the 9th of a month and she's having this card, she's enrolled under this, and she want to claim it, you cannot deny. And free of cost, you have to give the treatment. Hannah? So this is the thing. Okay. So that is the thing. Let's go ahead. The next is INIP. What is INIP? Intensified National Iron Plus Initiative. I repeat, Intensified National Iron Plus Initiative, INIP, Iron Plus Initiative. It comes under Poshan Abhiyan. It comes under Poshan Abhiyan. What is Poshan? Acha? Poshan is not this Poshan. There is a full form of Poshan. Pradhan Mantri. P is for Pradhan Mantri. Outreaching scheme for holistic nutrition. holistic nutrition. That is Poshan Abhiyan. So under Poshan Abhiyan, it is INIPI. Don't try to mug it up. You will become mad. It will be there in the options. You just have to pick the option. It is 6 into 6 into 6 strategy. I have already taught you what is 5 into 5 strategy. I have already taught you what is 5 into 5 strategy. It was RMNCH. It was 5 into 5. The 5 beneficiaries, you know. So HA. This was the strategy. And 6 into 6 into 6 is INIPI. So there are 6 beneficiaries. To these 6 beneficiaries, I will tell you who 6 beneficiary. We will give 6 intervention. And to these 6 beneficiary, we will give 6 institutional mechanism also. That is 6 into 6 into 6. Who are 6 beneficiary? What is the vision? Why we are giving intensified iron plus initiative? Why we are giving iron free of cost to them? We want an anemia Mukt Bharat. So the vision of this program is anemia Mukt Bharat. We want an India, there should be no anemia in that India. So anemia Mukt Bharat is the vision, the punchline given to this program. INIPI. INIPI ka vision kya hai? Anemia Mukt Bharat. What is the objective? Objective is reduction of the anemia prevalence by 18% in all the target groups by 2022. 2022 is already passed. ये बहुत पहले launch हुआ था, है ना? The 6 beneficiaries are 6 month to 60. Make it 60. 59 मतलब 60 होता है. 6 to 60 month. So 6 महीने से लेके 5 साल का बच्चा. 60 month यानी 5 साल ही होता है ना? So 6 to 60 month, all the male and female. बच्चों में anemia is very common, है ना? Because child do not eat much, है ना? So my kid is also not eating, है ना? So that is 6 months to 60 months. So anemia is very common in children. So if the child is anemic, iron supplement should be given thoroughly. Okay. Then 5 years to 9 years. Okay. Both males and females. 5 to 9 years also the second beneficiary. So 6 months to 5 year, 5 year to 9 year. Here both male female. Here both male female. 10 to 19 year adolescent. Again both male female. So 6 months to 5 year, 5 to 9. 10 to 19, male, female, male, female, male, female. है ना? After 19, take only females, 20 to 45. Take only females of reproductive age group who are non-pregnant and non-lactating. The reproductive age group females, 20 to 45. Don't take males in this group. है ना? After that, take pregnant. Of course, pregnancy only in females, not males. And take all lactating. So males are till 19 only. उसके बाद के males को नहीं ले रहे हैं. Got it? Say yes. So these are the 6 beneficiaries. Can you enumerate what are the 6 beneficiaries? Say, ma'am, 6 month to 5 year. Say 5 year to 10 year. Say 10 year to 19 year. है ना? 19 or 20, whatever. 20 to 45 pregnancy lactation. So here male and female both. Here also, here also. But here only female, only female, only female. Obviously lactation and pregnancy to सिर्फ female में ही होगा ना? But this is also only female. Got it? Say yes. So these are the 6 beneficiaries. So what करेंगे क्या इन सब का? इन 6 का क्या करना है? We will give 6 intervention. What 6 intervention? To these 6 beneficiaries, we are going to give 6 intervention. We want an anemia Mukt Bharat, है ना? So what 6 interventions we are going? We are going prophylactic iron folic acid tablets free of cost. Have you seen? Yesterday I have shown you the strip. So it is prophylactic iron folic acid tablets. These are the iron folic acid tablets, the red and the blue one. We will provide them free of cost. We will do the deworming. What do you mean by deworming? There are certain parasites. Have you heard the name of some parasites? These are known as hookworms. Hookworms, Ankylostomia duodenale and Necator americans. They drink blood in the intestine, and because of which the anemia is there. So you are keep on giving iron, but patient is still anemic still. So you have to do deworming also. And especially in children, the worms are very common. They drink blood, and that's why the child is anemia. Treatment of the anemia. This is prophylaxis. If the person is already anemic, treated. Hana, behavioral change communication. Behavior change communication. Always motivate them to eat the green leafy vegetables. Motivate them the things which have iron. Motivate them to eat the jaggery. You change the behavior by doing communication. Hana, talk with them throughout the year. Hana, mandatory provision of fortified foods. Hana, IFA fortified foods you have to give. Hana, iron folic acid fortification is done. Like salt, iodized salt fortification, iodine fortification is done in the salt. Vasa. And non-nutritional causes of anemia is there, you have to take it out. Hana, like malaria, fluorosis, or sickle cell anemia. These are the non-nutritional causes of anemia. So rule out that also. Address that also and treat it. So these are the 6 interventions. To these 6 beneficiaries, we are giving these 6 interventions. And there are 6 institutional mechanisms also. Don't learn, just have a look. Hana, don't learn, just have a look. These are 6 institutional mechanisms. Nobody is going to ask. So it's a 6 into 6 into 6 matrix. Maximum they can ask a question this. 6 into 6 into 6 is what? INIPI. INIPI ka vision kya hai? Anemia Mukt Bharat. What do you mean by 6 into 6 into 6? There are 6 beneficiaries, 6 intervention, 6 institutional mechanism, 6 into 6 into 6 strategy. How many of you got it? Can we go ahead? Hana? So iron folic acid tablets we give. Hana? For children, it's different. For adults, it's different. You can see. Hana? For adults, it's red color. For children, it's blue color. Okay. And for small, up to 5 years, the syrup is available. The syrup is there, not the tablet. Okay. Just that. Can we go ahead? Huh? There is a weekly iron plus initiative, WIFS. Weekly iron plus initiative is also there, in which every Monday, to all adolescents, boys and girls, in the Anganwadi, free iron capsule or tablet will be given. That is weekly. Hai? So that is the thing. Okay. So in EP mein anemia management protocol you can leave. I have told you the adolescent group. Now adolescent group mein you go to the school. In the school there should be a annual checkup who all are anemic. The one, it is under Rashtriya Bal Suraksha team. The Rashtriya Bal Suraksha team visit the government school once a year and they will check the hemoglobin of all the children, the adolescent boys and girls there. So whosoever is anemic, whose hemoglobin is between 8 to 12, that is anemia. One tablet is given for 3 months. Hana, under school teacher supervision. You can see she is a school teacher. She is giving the tablet one by one and he is the recorder. He's just ticking that we are giving the tablet to all. These all are anemic. Hana, these all have hemoglobin 8 to 12. So these all are anemic. So they will be given free tablet for 3 months, once a day, given under supervision, and it is under the supervision of the school teacher. Hana? And after 3 months, we will do the follow-up. The first follow-up is after 45 days and second follow-up after 19 days. If no improvement in 3 months, Hana, then we will refer it. Maybe some other causes there. So this is adolescence, how we do under Rashtriya Bal Suraksha Karyagram. Got it? In pregnancy, where we do? In pregnancy, we do it at ANC clinic. At ANC clinic, we know that we give them free iron folic acid tablets. Can I proceed? The next is Lakshya. What is Lakshya? What is Lakshya? Say the full form. Labor room. L is labor room. Labor room. L is labor. Labor room. Quality improvement. Quality improvement initiative. Hai Labor room quality improvement initiative is SHAYA, don't have any full form. So Lakshya is labor room quality. It is related to labor room quality. So improved quality of the labor room should be there. Hai Improved quality of care provided to the pregnant lady in the labor room and maternity operation theaters. Okay. So that is the thing, so that we can reduce the preventable maternal and newborn mortality. So these all initiatives are taken by the government. This is Lakshya. Okay, labor room quality improvement initiative. Just learn the full form, learn the logo. Learn the logo, it's like a hit, it's a target. And this is Lakshya. You can get image-based question on that. Say yes, say something, respond. So these are the national programs. You just take one line in them. Sabka goal, target, objective, don't learn that. Nobody is going to ask you that. At your level, this much is sufficient. You should know the name of the programs, what all are working. You should know their logos and main points in that. That's it. Okay. Navjat Shishu Suraksha Karyagram. Navjat Shishu Suraksha. Now it's not maternity. It's the newborn. It's a newborn. So train the doctors and train the Anganwadi workers for basic and resuscitative newborn care and urgent referral. Hana? So if you are a A&M worker or if you are a doctor, you should be trained. So training is given in this. Hana? So we provide home-based post-neonatal care. It was launched in 2011. Asha will give how many visits? 1 prenatal visit at the 8th month of the gestation. Hana? 1 prenatal. 6 postnatal visits. 6 postnatal after delivery. Hana? If home delivery is taking place. Hana? We are trying to give Janani Suraksha Yojana. But still after that, many mothers say, no, I do not want any money. I will do home delivery only. I will not do institutional delivery. Okay, you do home delivery. Asha tried to convince her, but she is not convincing. She is saying, I will do only home delivery. I will not go to hospital. Hana? In my own environment, I will do the delivery. So, okay, do the home delivery. So after home delivery, Asha will do 6 visits. How many visits? 6 postnatal visits to the home of that lady on day 3, on day 7, on day 14, day 21, day 28, and last visit on 42. Hana? So this is the total 6 visits. 7 visits. I'm sorry. No. 6 visits in case of institutional delivery. Because institutional delivery, the delivery is done in the hospital. So on 2nd day, the lady is discharged, or maximum 3rd day. Hana? So she is discharged on 2nd day only. So the next day, the Asha is going to the home. And in case of home delivery, 7 visits Asha is doing. 1 visit extra on the day of the delivery. Hana? And in LSCS, only 5 visits are required. Hana? Day 1 and day 3 are skipped because LSCS cannot take place at home. It will take place in hospital only. Okay. So this is home-based post-neonatal care. Home-based. Can you see? There is a home. You can see there is a home. You can see there is a mother. You can see there is a jhula, है ना, in which there is a kid, है ना. So home-based care we are giving, है ना. The mother and king, they are not coming to the institute. The Asha is visiting 6 times or 7 times and giving the care there. Okay, so that's all about the mother programs. Can we start the pediatric programs now? Can we start the pediatric programs? The pediatric programs, maybe half an hour more. We will finish. Are you people there? Okay. So let's continue with the pediatric programs. Let's finish it off without any break. Hana, maybe half an hour or 40 minutes, we will just pack the PSM. Okay, if we take the break, unnecessarily, it will be stretched. So pediatric programs. In the pediatric programs, the first is the neonatal care under RMNCHA. So I'm talking about this neonatal care. Hana, so how many types of neonatal ICUs are there? So, you know, in the labor room, whenever the delivery takes place, as soon as the newborn come out of the mother, either the vaginal delivery or the cesarean section, in all labor room, there is a corner. It is known as newborn care corner. Hana? So as soon as the newborn come out, pediatrician take care of the newborn. The gynecologist, so there are two people in the labor room. One is obstetrician, and one is pediatrician. So obstetrician take care of the pregnant lady, the mother, at the time of the delivery. As soon as newborn come out, obstetrician don't look for the newborn. The pediatrician will take care of that. So there is a separate corner in the labor room itself. So they take the newborn in that corner. It is known as NBCC, newborn care corner. At the point of the delivery only it should be there. So newborn care corner is there. Okay, newborn care corner is there. So healthy, if the newborn is healthy, just after that, Apgar score is done. And basic, we will see everything is okay. There is no congenital disorder grossly visible. Apgar is normal. We hand over to the relatives. We hand over the newborn to the relatives. We are done. Anna? And we shift the mother to the ward or recovery room or whatever. Okay. And after, within half an hour, we try to start the breastfeeding. We try to do the room in. That is same room in mother and baby should be there. And we hand it over to the relatives. If the newborn is healthy. If the healthy newborn is there. Okay. But if the newborn is sick, what we will do? So after NBCC, we will take it to NBSU. That is newborn stabilization unit. It's there in the hospital, newborn stabilization unit. We will try to stabilize it. We will try to stabilize. Sometimes the newborn is not crying. So we will try to stabilize. We will try to give some ventilation or something. We will try to make it cry. Crying means breathing. If the newborn is not crying, not breathing. Because inside the uterus of the mother, newborn was not breathing. The fetus was not breathing. The fetus was getting the oxygen from the placenta itself. As soon as it comes out, the placenta is cut. And now the oxygen is not provided by the placenta. So newborn has to breathe of its own. So first time the air will go inside the birth, inside the lungs. So first cry of the baby is the first breath of the baby actually. So baby not crying at birth means they are not breathing. So ventilator or some support is required. So that will be given in newborn stabilization unit, NBSU. NBSU. But some here NBSU basic care we will give. But some newborn are very sick. They are very sick and they require ventilator or some major surgery to save them. So they are shifted to SNCU, sick newborn care unit. Sick newborn care unit. Okay, they are shifted there. So in the labor room, it is NBCC. After that, then if the newborn is healthy, they are handed over to the relative. If not healthy, they are shifted to NBSU. If not very sick, they are shifted to SNCU. You should know their full forms. Newborn care corner, newborn stabilization unit, sick newborn care unit. Say yes. And if they are not taken care, they are referred and they are further referred to the district hospital. Okay, if we require, we will refer them. So this is the complete care we provide. Say yes. Say yes. So all the newborn are in NBCC, but the sick newborn in NBSU and extremely sick newborn is SNCU. I told you the full forms. Here only one graduate doctor, MBBS doctor will also work and one nurse is there. Here one pediatrician is required. Here one MBBS doctor can also assist the obstetrician. Here NBSU at least one pediatrician should be there. And here along with one pediatrician, 2 to 3 MBBS doctors along with 14 to 16 nurses are there. This is 0 bedded, this is 4 bedded, this is 20 bedded hospital. So this is the newborn care. The next we are studying is Rashtriya Bal Suraksha Karikram, RBSK. Rashtriya Bal Suraksha Karikram. The next one. So what does this say? Now this is not regarding the newborn. This is regarding the children. This is the logo. You can see. Oh, I'm sorry. This is the logo of National Health Mission. So Rashtriya Bal Suraksha Karikram, I'm telling you now, there has to be screening of 32 diseases. There has to be screening of 32 diseases. Screening of 32 diseases in the children. This was launched in 2020. The screening has to be done in 0 to 18 years of age. This is known as BAL group. BAL yani bacche. 18, up to 18 years. And if any disease is found, free treatment is given. So what are the 32 diseases, can you say? We divide the 32 diseases into 4 groups. DD. Defect at birth, the diseases due to deficiency, the diseases of childhood, and diseases due to development. Hana? So let me tell you, out of 32, you can see these are the 32. 9 of them are defects at birth. Screen it. Does the newborn have neural tube defect, Down syndrome, cleft lip, talipes, dysplasia, congenital cataract, congenital deafness, congenital heart disease, retinopathy? Don't learn. These are the defects at birth. These are the deficiency, not present at birth, but later on. Due to iron, there can be anemia. Due to vitamin A deficiency, there can be Bitot spot. Due to vitamin D deficiency, there can be rickets. Due to protein deficiency, that is malnutrition. Due to thyroid deficiency, there is goiter. So these are developed later on. Anna? And these are the diseases of the childhood. Like skin diseases are very common. Scabies is common in children. Otitis media, rheumatic heart disease I taught you. Airway diseases, dental caries are common. Convulsions are common in children. And these are the developmental delays. Vision impairment, hearing impairment, neuromotor, motor delay, cognitive delay, language delay, behavioral disorder, autism, learning disorder, and attention deficit hyperactive disorder. Okay, so all the 32 diseases should be screened and freely treated. It is Rashtriya Bal Suraksha Karikram RBSK. Screening is done at multiple level. Screening is done in the school. In the school. These are the 32 diseases in front of you. Say yes. Got it? So where the screening is done? 0 to 6 week, it is done house to house. It is done by Asha. 6 to 6 years, it is done by Anganwadi worker. And 6 to 18 years, it is done in the school. So screening is done. Screening is done and free treatment is provided to them. Okay, we are done with the programs for the pregnant ladies, mothers. We are done with the programs for neonates. We are done with the programs for children. I told you many programs. Here the main program is Rashtriya Bal Suraksha Karikram. For neonates, I told you home-based neonatal care. And for pregnant ladies, I told you many programs. Pradhan Mantri Wali. And now I'm coming on adolescent group. Adolescent. I'm teaching you this now. RMNCHA. So lastly, adolescents. We have already seen maternity. We have already seen neonate. We have already seen children. Now, reproductive, I have told you there only in family planning yesterday. So I'm coming on adolescents lastly. So this will be completed. So I'm coming on adolescent programs. Can I come on the adolescent programs now? In the adolescent programs, the main program here is the Rashtriya Kishore. Who is Kishore? Kishore is a young like adolescent person is known as Kishore. Swasthya Karikram. Rashtriya Bal nahi. Initially, I taught you Rashtriya Bal Suraksha Karikram, and now I'm saying Rashtriya Kishore Suraksha Karikram. Rashtriya Kishore Suraksha Karikram launched in 2014. It is for adolescents, both boys and girls, 10 to 19 years of age we cover. So this is the logo. You can see they are playing with a kite. You can imagine the age. So it's 10 to 19. You can learn the logos of all. Okay, there are 6 priorities here. We should take priority of their nutrition. Number 1, in this age group, we are talking of age group of 10 to 19 years. You should take priority of their sexual and reproductive health. Mental health, very main. This is the very delicate age. Mental health. Substance misuse. This is the most common age when they can misguide by someone and they can do the misuse. Like looking at the television, someone is smoking, they can start smoking. They can start gutka chewing. They can start drinking alcohol like that. Injuries are very common in this because they play games, outdoor games. Injuries are common, and violence. Sometimes violence and non-communicable diseases are common. So 6 priorities are given. These are the 6 priorities for this age group. Rashtriya Kishore Suraksha Yojana. Understand, don't learn. School health program also come here because in the school maximum crowd is adolescent age. Most common, I told you yesterday, dental caries are most common in the school population. Medical examination done every 6 months. Eye checkup is done by the school teacher. We train the school teacher how to do it. Every 150 student, one school teacher. And it is done from class 5th to 8th. 5th to 8th class के बच्चों का करेंगे visual checkup in the school free of cost every 6 months. And 10 to 14 years of age group. 5th to 8th यानी 10 to 14 years ही होता है. In 10 to 14 years, the child is in 5th to 8th class. And we will ask the teacher if any of the child is less than 6/9 vision, refer it to the PHC. The child will come with this to the PHC. We will examine, confirm, and give free spectacle. We will give free of cost glasses and spectacle to the child, free of cost. No, nothing, no charges will be taken. So the teacher will refer it to the PHC. Anyone who is having visual acuity 6/9. So learn what is red, red, red. Just learn that. Got it? Now 3 programs I'm going to teach you which sound similar. Ujala, Ujwala, Ujawla. Little bit difference. है ना? This is Ujala. This is Ujala. है ना? What is Ujala? Light. Ujala is what? Light, if you know Hindi. So this is a program in which affordable LEDs are provided to the village people. Affordable LEDs. The LEDs are at very affordable price. है ना? So that is Unnat Jyoti. This program is run by Unnat Jyoti. है ना? Affordable LEDs. है ना? It comes under domestic efficient light program. Domestic efficient lighting program. So this is domestic efficient lighting program, Ujala program. You can see an LED is dancing here. है ना? So this is Ujala. The second is Ujawla. Ujwala, I'm sorry, not Ujawla. Ujwala. 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 Who is Ujwala? Ujwala is a lady, है ना, who is cooking on LPG gas. We want all the ladies in India, don't cook on the coal. Don't cook on the wood. Don't burn the wood and cook on that. Don't cook on the coal. We will provide free LPG gas. है ना? So the government is giving subsidy, है ना, and free LPG gas to all the poor ladies. So the name of the lady is Ujwala. She is a Ujwala, है ना. She will cook on the LPG. So all the ladies who are below poverty line, we will give them free LPG gas, है ना. And the next is Ujawla. Ujawla is prevention of childhood sexual trafficking. You know, nowadays there are many groups, especially the girl childs, they take it to some other countries, and for sexual trafficking gangs are there. So prevention of that. So rescue them, rehabilitate them, reintegrate them. है ना? Recently many gangs are found that they are doing so. है ना? They take the adolescent girls or small girls, or not only girls, the boys also, and the sexual trafficking group is there. So that is Ujawla. है ना? So that is the 3. So please learn the 3 programs, Ujala, Ujwala, and Ujawla. You usually get question on them because they sound similar, no? Say yes, people, say yes. है ना? Say yes. The next is free days, menstrual hygiene program. So in the females, है ना, in the adolescent females, menstruation every 28 days, है ना. So name of this program is free days, है ना. So free sanitary napkins are provided free of cost, है ना, by the Asha to the adolescent girls, है ना. But initially it was free. Now it is chargeable at a very nominal price, that is ₹1 per pad. So 2 types of pads are available. Free days. This is free days. Anna, these are the sanitary napkins. These are free of cost. But the second one, Suvidha. This one is Suvidha, you can see. Anna, this one. It is ₹1 per pad, and these are biodegradable sanitary napkins. These are ₹1 per pad. So that is the free days. We are done with that. Now, infectious disease program, really not very important. The TB and malaria is there. You can read off your own. TB mainly you will read. RNTCP guidelines, I will tell you. Learn the logo of the TB first. You can see TB Mukt Bharat. You can see a person dancing, red color person dancing like TB Mukt Bharat. So this is the logo, है ना? TB हारेगा, देश जीतेगा. This is the punchline we gave. TB हारेगा, देश जीतेगा. National Tuberculosis Elimination Program. National Tuberculosis Elimination Program का logo है ये. You can read. See, है ना? Got it? Okay. Yes, all the programs are working in all the states, Mahima. Many programs are working in few limited states, but in PHC, wherever there is a PHC, all these programs are applicable. Hana, so PHC. So basically, the programs are in the rural areas. Hana, in the PHCs they are working. In the government hospitals they are working. In all government hospitals. So let's go ahead. National Tuberculosis Elimination Program. This is the logo of the TB. You can see, Hana. So don't learn all these things. Okay. Don't learn the numbers and figures. Control of TB. From here you can come. Okay. Sputum collection. Sputum collection under National TB Elimination Program. Imagine any patient who is having cough for more than 2 weeks, and the person is taking the antibiotic but unable to treat it till now. Okay, just a second. Cough since more than 2 weeks. Hana, fever, especially in the evening. Hana, hemoptysis means cough contains the blood. When coughing, the sputum is containing the blood. Unexplained weight loss and reduced appetite. Whenever any person presents, so it is the indicator you should do the sputum collection for TB. Maybe the person is having TB. Learn the 5 indications. Okay. How many sputum collections you will do? Hana, we will do 2 sputum collection. First, on spot. On spot. The patient is coming to you. On spot, give a sterile container. Provide a sterile container, ask the patient to cough, and provide a sputum in a sterile container and submit it to the laboratory. That is on spot, label it as E. Hana, second container, empty container you provided for home. take it to home, and early morning, the next morning, the first sample you will give and submit it to the laboratory. That is label it as B, है ना? And labeling is done on the container. Say patient का नाम, है ना? Patient का whatever is नाम, X, Y, Z. Write it here. Don't write the name. Initially we used to write it sometime on the lid यानी ढक्कन. तो ढक्कन तो exchange हो गया. I'm having 10 samples with me. So I am a technician. I have opened all 10 samples. सबके lid open किए और मैंने उल्टे सीधे लगा दिए. Report उल्टा सीधा चला जाएगा. So labeling is never done on lid. It's a rule in the lab, है ना? On the microbiology, pathology lab, never do the labeling on the lid. Lid can be interchanged ना after opening. Once open, you are not sure कि कहाँ से open किया. ये सब open कर दिए मैंने, दो एक साथ open कर दिए. मैं भूल गई कौन सा ढक्कन किसका है. उल्टा लगा दिया तो भाई एक positive था एक negative था. Movies में देखा है ना? So उल्टा सुल्टा report नहीं चाहिए. So we will do the labeling on the container, not on the lid. So take 2 samples. Now, if any of them, this is sample A on spot, this is sample B, the next day early morning sample. If any of them, this is positive, this is negative, or this is positive, this is negative, or both of them are positive, I will consider the patient as TB. If any of them is positive. If both of them is negative, then it will be negative. I will consider it as negative. And we will ask for this PCR. We can ask for PCR, which is more specific. Can we go ahead? So this is how sample collection is done. And who is a case? Who's a new case? A patient of TB who has never taken the treatment of TB in the past, who has never taken the DOTS treatment in the past. That is considered as a new case. Who is a previously treated case? Who has received at least 1 month of treatment in the past and left in between. That is known as previously treated. है ना? So resistance बाद में देखते हैं. Let me teach you the treatment first. Just a second. The new treatment guidelines. So the new treatment guidelines, there are 2 phases. Have you heard about the 2 phases? Intensive phase and continuation phase. What is intensive phase? In intensive phase, we give the treatment to the patient in front of us. I mean, it is supervised. It is always supervised. And continuation phase, only the first dose is supervised. For example, we divide the patient into 2 categories. Intensive phase, continuation phase. Okay, we divide the patient. This is a new case. This is a new case of TB. Okay, this is a new case of TB. So for the first 2 months, patient has to come daily to the hospital. In front of me, I will give a tablet and patient has to take the tablet in front of my eyes. Not only the doctor, any healthcare provider can be the supervisor. In case the child is going school and cannot come to the hospital daily, school teacher can be the supervisor. In front of the school teacher, that has to. So in front of someone, it should be confirmed that the patient has taken the treatment, the tablet that day. So you know how many anti-tubercular drugs are there? There are 5 anti-tubercular drugs. HRZES. Is pharma class done? You know what is HRZES? I guess everyone knows H is isoniazid, R is rifampicin, Z is pyrazinamide, E is ethambutol, and S is streptomycin. These are the 5 anti-TB drugs which are provided to treat the TB. So out of them, which 4 are given? Here 4 are given, HRZE. S we don't give. S is injectable. We don't give S here. So in intensive phase, we give only 4. Combining we make 1 tablet, a big tablet. And patient has to take 7 days a week. Daily patient has to come for the 2 months, and we will give one tablet containing 4 things inside that. We don't give 4 different tablets. We give 1 tablet combining all 4. Say yes. Got it? And in continuation phase, the next 4 months are the continuation phase. After that, patient has to come every Monday. In every Monday, the first dose patient will take in front of me. The remaining doses the remaining 5 doses or 6 doses, I will give it for home. The remaining 6 doses. Out of the 7, I will give the remaining 6 doses for the home only. And the next Monday, patient has to come with an empty strip. So that I will be assured that you have taken all the doses at home. Then only I will refill. For the next week. Every week patient has to come. The first dose is supervised. Here I will give only 3 things. HER. I will not give Z. So here 3 things combined and I will make a smaller tablet. And we will give them. Say yes. Got it? This is the new guidelines of the TB treatment. Say, people say. So this is how you can see. So this is the tablet containing 4 things. HRZE. You can see this is a relatively bigger tablet. So this has to be taken in intensive phase. The name of the tablet is 4 fixed drug combination, FDC tablet. It contains 4 drugs inside that. 1 tablet containing 4 drugs. This is known as 4 FDC. FDC is fixed drug combination tablet. And this is containing 3 drugs only. That is H, R, and E. It doesn't contain Z. So this is given in continuation phase. So first 2 months this one, and then later on 4 months this one. Say yes. Got it? This is how we provide the treatment. This is DOTS. I'm teaching you DOTS. So this is known as DOTS. Directly observed therapy, short term. So this is the treatment under dots. So whatever new patients are there, ask them total 6 month का treatment है. Total treatment is of 6 months. Out of the 6 months, the first 2 months is intensive phase and the next 4 months is continuation phase. Here you have to come to the hospital daily. It will be all the doses are supervised. And here you have to come to the hospital once a week. Every week. We will decide a day every Monday, every Tuesday. And the first dose is supervised, rest are given for the home. This is like that. Say yes, got it. This is like that. So here we will give you 4 tablets. I mean 1 tablet containing 4 drugs. I will give you 1 tablet containing 4 fixed drug combination, 4 FDC. Here I will give you 1 tablet containing 3 fixed dose combination. So here I will give you HRZE. Here I will give you HRE. Anna, I have shown you the strips also. Say yes. So this is how we treat a new case. A case who has not taken the TB treatment in the past and first time the patient is having TB. So this all you will read in pharmacology also. In pharmacology also you will you will read it. Better you will read it. Okay. That's it. Hannah, I'm not going in the detail. Okay. One more thing I would like to tell you. What is this pronunciation? Nikshay Poshan Yojana. Nikshay Poshan Yojana. What is this Nikshay Poshan Yojana? It is launched by Ministry of Health and Family Welfare. Now, you know, all the TB patients, they are deficient of protein. They are very lean, thin, they are underweight. That's why the TB occurred to them. So whenever we treat them, we want they should eat very well. A high protein diet we recommend. They should eat abundant of paneer. They should eat abundant of cheese if they are vegetarian. If they are non-vegetarian, they should eat abundant of egg. Hana, we want them. But most of the patients says we are very poor and we don't have money for the nutrition also. So what the government is doing? Government is providing every month 500 rupees in the account, financial benefit till the treatment lasts to all the TB patient. Hana, it was launched on 2018. After 2018, all the new TB patient, they are given additional 500 rupees per month. In the tribal area, 750. This is for their nutrition. So we assume that 500 they are taking good nutrition throughout the month and good protein diet they should take. This is known as Nikshay Poshan Yojana under the TB. Got it? But direct beneficiary के account में ही जाएगा, the person who is having the TB, उसी के account में जाएगा, and it should be Aadhaar linked account. It is centrally sponsored scheme. And all states and union territories of India are there. So anyone who is having TB can enroll for this, that I want additional 500 rupees per month for having good nutrition. If the person is very poor and cannot afford for the nutrition, government will provide 500 rupees per month. है ना? MOHFW is Ministry of Health and Family Welfare. Ministry of Health and Family Welfare. है ना? So this is the ministry who is doing the sponsor from central government. So, you know, funding is important, Simran. Everywhere funding is important. है ना? Programs तो आ जाते हैं, लेकिन पैसा कहाँ से आएगा उनको run करने के लिए? So it is the ministries which are divided. Ultimately, that is giving the financing and funding everywhere. So that is the thing. Okay. There's one more very important program, 99 Dots program. What is 99? It's very important. Listen. So I told you now in intensive phase, what we are doing, patient has to come daily to the hospital and in front of my eyes, patient will open. I will give the tablet to the patient. I will open the strip and I will take the strip, take the tablet out and I will give. And in front of me, he or she should take. So there is no doubt in that patient has definitely stick to the treatment. And it's in record. I have watched that. I or any of my sister, nurse, any of my technician working under me, I will give the responsibility to them if I'm very busy. Okay, so that is intensive phase. In continuation phase, we are monitoring only first dose every Monday. What about the others? I'm giving the rest of the strip for the home. I'm asking come next Monday. If the strip is empty, I will give you next strip. So patient is going and after that he's throwing just the tablets. Maybe he's not taking, or on the last day before coming, just he's taking it out, making the strip empty and giving it to me. So how I should know कि at home he has taken the treatment properly? कोई तरीका है उसको पता करने का कि घर पे उसने अच्छे से रोजाना ट्रीटमेंट लिया है मंडे से लेके अगले मंडे तक उसका कोई तरीका है yes we are doing online monitoring that is known as 99 dots program online monitoring of the treatment adherence is important treatment adherence in TB HIV patient both of them this program works है ना so the strip contain the hidden phone number randomly not all so see this is the blister of the tablet I'm providing for home you take this blister at home so whenever the patient and this is the start point it is written ki start from here only and arrows are there it is not ki first tablet yahan se le liya second yahan se no you cannot do that I will warn the patient that you go with these arrows only so start from here and you can see the arrow then here open like in this sequence only you cannot open anything so the first strip The patient is opening, nothing is written here. The second, you can see there is a hidden mobile number. So I will ask that any of the blister tablet contain a hidden mobile number. Whenever you find a hidden mobile number, give a missed call on that number. Every number is unique, every number. So a series of missed call are numbers we track, and it's computer algorithm, it's software. We don't do that. So the computer know कि इसमें कहाँ पे algorithm में it is already there कि which of them is containing the phone number. You can see here phone is drawn, here phone is drawn, here phone is, so it is having the numbers, है ना. So we know कि on day 2 पे कॉल आना चाहिए, फिर 3 पे नहीं, 4 पे नहीं, 5 पे नहीं, फिर day 6 पे कॉल आना चाहिए, फिर 7 पे नहीं, फिर day 8 पे आना चाहिए, फिर 9. So on that day the call should come. अगर any call is missed, automated SMS service is there. Automatic free call भी जाएगा hidden free इस पर, और a series of daily reminders भी जाएगा कि today you have missed the dose, today you have missed the dose, like that, है ना. So missed doses trigger SMS notification to the care provider. SMS notification patient को नहीं जाएगा, उसके care provider को भेजेंगे. अगर बच्चा है तो उसकी mother father को SMS notification जाएगा कि today's dose is missed. Got my point? So this is the 99 dots program. How many of you got it? It is an online monitoring of the adherence of the program, है ना, through fixed missed call, है ना, a free call to the hidden phone number, है ना. A series of missed calls are there, and SMS and automated calls will come on that number if someone is missing that. So this is 99 dots. See, government is doing how much, है ना. Many things are doing the government, people don't appreciate. Okay, so to remove, to eliminate, to decrease the incidence, to control the disease, government is doing too much. Okay, only thing, patient should adhere to the treatment. The treatment is free, the diagnosis is free. For adherence also multiple programs are there. For nutrition, additional 500 rupees are given to them. What else the government will do? Hana? So these all are the programs. You can see this is 99 dot strategy. You can see the phone numbers. This is having a phone number, this one. So on that particular day only the call should come. It is not necessary कि पहले दिन यहाँ call कर दिया, दूसरे दिन यहाँ. So on day 1, on day 4, on day like that only the call should come. So we assume कि बीच के doses भी लिया है. The missed call should be there. है ना. So that's the only thing, है ना. Okay, you know 4 FDC, you know 3 FDC. This is for adult. For pediatrics, you will learn better in the pharmacology. I guess pharmacology is a better subject to teach you the doses there. Okay, so that's all about it, I guess. Don't see the detail, that's all about it. That's all. Apart from that, there are few miscellaneous programs I have enumerated. I want you to read those miscellaneous programs. Just have a look on one word of them. Don't go in the detail. Don't go. Hana, main programs we have already covered. All the main programs I have covered. Miscellaneous program, you can see Kaya Kalp program. What is Kaya Kalp? It is Clean Hospital Initiative. This is Kaya Kalp. Can you see a tree is there? It's Clean Hospital Initiative. So every month, 2 best district hospital in the state will be announced. 2 CHCs will be announced, and 1 PSC, every district will be announced. That is the cleanest one. So, you know, inspections will be there, and who is the cleanest one? That will be announced. That is the categories. Hana? And there is one more program. Just a second. Pradhan Mantri Jan Dhan Yojana, I guess everyone knows, na? Jan Dhan Yojana, do you know that? So it is interest on deposit. Hana? Accidental insurance cover up to 1 lakh and no minimum balance. So the Pradhan Mantri, respected Mr. Narendra Modi have opened, launched this Yojana that all the people in the country should have their bank account. Hana? With minimum no balance required. If zero balance is also there, it's okay, no penalty is there. Minimum balance. Hana? The faida, what is the benefit to the person who is opening the account? Free health insurance, or not health insurance, accident insurance of 1 lakh. If accident of that person who is having the bank account, free insurance will be given up to 1 lakh, number one. And if you are doing the deposit, then interest will also be given, like every bank do the interest on deposit. Hana? And a life cover of 30,000. Yes, if the person dies, 30,000 is given to the family. Anna, on the death of the beneficiary, the 30,000. So these are the benefits of that. Anna, so that is Pradhan Mantri Jan Dhan. You can see a rupee at the center. Anna, so Pradhan Mantri Jan Dhan, and overdraft facility is there. Overdraft facility up to rupees 5,000 is available. So Pradhan Mantri Jan Dhan Yojana. Mera Aspatal, My Hospital Initiative. What is Mera Aspatal, My Hospital Initiative? It's an app. You can also open in your mobile. You can see in the Play Store also. These apps are there. Anna. So this is implementation of public and private hospitals. Anna. So patient can write his views on the quality of the experience he get in any of the hospital. Hana? So it's like review. Hana, you are visiting some hospital and patient can freely give the review on this. All the hospitals are there and they can give the review what is their experience in that hospital. Okay, so that is Mera Aspatal, My Hospital. Got it? Bedsheet color in the hospital. Hana? So there is a Fixed protocol. In all the government hospital, every Monday white bed sheet should be there. Every Tuesday pink, every Wednesday green, every Thursday violet, every Friday purple, every Saturday blue, every Saturday gray, every Sunday gray. Because daily bed sheet has to be changed. So it compels the staff to change the bed sheet every day. So that is bed sheet. So that is for cleanliness. Okay. So that is the thing. Rashtriya Vayoshri Yojana. The free aids are provided to the old people. Old people, if they want walker, if they want the crutches to walk, so physical aid and the wheelchairs, assisted living devices will be given to senior citizen below poverty line. Hana, it is under the Ministry of Social Justice and Empowerment. Just have a look. Don't learn them. Don't learn. Free dialysis is there. Hana, E-Rakt Kosh. All the blood banks are integrated. There is an app, E-Rakt Kosh app, in which all the blood banks throughout the country, they are integrated. So if any rare blood group is required, that can be checked instantaneously that throughout the India where this blood group is available. So that is E-Rakt Kosh. And an online registration system. Nowadays, appointment can be taken online. It is not necessary physically you go and take the appointment. In government hospitals also, there is a ORS portal. So with this app, online registration, everything is digital. So online registration has to be done. Online appointments, doctor appointments has to be taken. National E-Record Authority, NEHA, National E-Health Authority. What does it mean? It means all the records, there is no file of the patient now. All the records are electronic. All the records of the patient are electronic. So patient have a number in the hospital and all the records are electronic. You fill that number, all the records will come automatically. So all the investigations done in the past. So everything is electronic now. Okay, so that is the thing. AM cessation program. What is AM cessation program? AM cessation program is the one who want to quit, who want to cessation of alcohol or tobacco or smoking, not alcohol, of smoking. So they can enroll for that. It's an app. They just install the app, or they just give a missed call on this number. So they will get a free SMS service. They get a free SMS service and they will get the tips that how to do the quitting. They will get the tips for that. So give a missed call on that or register online. You can see AM cessation program to live tobacco-free life. To live tobacco-free life. You can see this is the logo. You can see it's visible. Okay, so these are important programs. You can see, just read them. I mean, they are not important. They are not yet asked, but it's given everywhere. So I'm telling you, that's it. So that's it. I will not go further. That's it. Swachh Bharat Abhiyan. Indore is #1 city and I reside in Indore. That's why I'm telling you. So Swachh Bharat Abhiyan in 2014, it is launched. This is the logo. This is the specs of Mahatma Gandhi. So it is the vision of Mahatma Gandhi to see a India which is clean. That's why the specs of the Mahatma Gandhi is there. Ek kadam swachhata ki aur. That is the punchline. Swachh Bharat in one of the two spectacles. And you can see a flag, the tricolor in between. So everyone have a very peculiar logo. You can see it's a national campaign to clean the roads, streets and infrastructure of the country, to eradicate and the open defecation completely. So we are trying to do so. So that's it. We are done. Thank you so much. So anyone having any trouble, any doubt till now, please ask. National Health Program, you don't get much questions. Mainly questions is from maternal health, child health, neonatal health that we have already covered. Important programs. Say yes. So what do you want from my side now? What else? We are done with PSM. How satisfied you are in PSM? How confident you are in PSM? How much you grade yourself, your confidence after completing everything. So we have completed all the 18 chapters in PSM. All A to Z we have covered. Nothing we have left. Are you confident now? Do you feel all the 35 questions you will be able to do? So try solving MCQs. I tried to solve maximum PYQs in the class itself, but whatever is left, you can solve by your own. So anything else you want from my side? Don't hesitate. You can tell me frankly. Don't hesitate. Thank you so much for your patience and bearing me and studying with me. Thank you so much. Okay, I will share the annotated versions. Apart from that, anything else? Yes, PSM is very simple subject, very simple, really. Karthik, it's very simple. Just the thing, you have to understand the things. Whatever you have to do rectification, I cannot help in that. Okay, but whatever is the conceptual, I try to give the concepts. Now you will not forget. Don't try to mug it up. Just try solving question as many as you can. As many as you can. If you want any help from my side, kindly let me know. Yeah, I'm coming for micro, Sheldon. Don't worry. Entire micro I'm going to cover in a very, very fun loving way. Micro will also become fun for you. So the 35 questions of the PSM we have covered and 15 questions of micro we will cover. Out of 300, this is my contribution. So I guarantee these 35 and the next 15 for micro I will come back. maybe the dates you also confirm from the team from my behalf. And if you are confirmed, kindly let me know also. Please, Hannah, you ask the team and let me know. Okay. Other subjects, Gaurav, team has not asked me to do that. Hannah, so NLC team is giving PSM and this micro to me. Okay, so PSM is done, I guess, and micro I'm going to take further. Dates are not confirmed. Okay, confirm from the team. Thank you so much. Bye-bye. Wishing you all the best. Hope to see you again in the micro class, but not in the next batch. I want all of you to get selected in this December FMG. Yes, in this December FMG, I want all of you to get selected, means to get your certificates. And after that, I want all of you to crack your entrance exam with very good rank and be very good physicians, surgeons, doctors, and a good human at all. Thank you so much. Bye-bye. And that's it. I'm ending the session. Bye. Good day. Hope to see you again in micro. Okay. Bye. I will confirm the dates once I will be confirmed. Okay. Bye. Don't forget to give your feedback to the team now. Whatever is your feedback, I'm not saying only positive. Whatever is your feedback now, write it to the team. Wherever you give your feedback, I don't know, on the Telegram, WhatsApp, you may be having some group now. So whatever is your feedback with the PSM, Hannah, regarding the content, regarding the completion, regarding the images, regarding the speed. I know speed, you all will give negative score to me. Many people complain that my speed is a little bit high side. But if you imagine, if you don't keep the pace, how the subjects will be completed. It's a vast subject. If I keep slow speed, only 50% will be completed. Hannah. So that's the thing. Okay, so please give the feedback. Thank you. Bye-bye. See you again.